Okay, so um, today we are going to continue by talking about the restrictive lung disease. And I just want to know that we'll try to move as fast as possible so that we can quickly complete this our pulmonary module. So um, we can just leave our questions maybe till the end of the um, lecture, or when I ask if we have any question, so that we can move very fast. So the restrictive lung diseases are just group of diseases that are associated with loss of lung compliance, causing increase in lung stiffness. So we already know this. When the lung is very stiff, it's not compliant, because the way you look at compliance, is like a phenomenon associated with increased tendency for a cavity, or like let me say an organ, you know, to change in volume in response to pressure. So if you kind of add more, um, or how do I say it now? Like if if a lung is compliant, if you add more pressure to that lung, you expect it to increase in volume, like to be able to accommodate what you are adding. But if it's not compliant, it becomes stiff. It cannot change in volume because it cannot stretch. So that's like a way to look at compliance. You are trying to pour water into something. If it's compliant, it's going to expand to accommodate that water. But if it's not compliant, it will remain stiff like that, and it will not, you know, take that water, and the pressure will kind of build up. So that's compliance. So compliance is just talking about change in volume with respect to the pressure. So it's a very, very important concept to remember with respect to restrictive lung disease. They are not compliant. The lung is not compliant in restrictive lung disease, and the stiffness is very, very increased. You can look at this stiffness as also elastic recoil. Elastic recoil is a tendency for the lung tissue to come together and kind of recoil on itself, come together, generate a positive pressure to bring air out. That's a very simple way to look at elastic recoil. And a lung tissue that is very stiff will have a high elastic recoil because it cannot stretch, it cannot move outwards, but it can move inwards. And elastic recoil is kind of trying to push the lung inwards so that they can force air out. So it means that if they say that something is stiff, you can also interpret that as having a high elastic recoil, and expansion is going to be reduced because it can't stretch. It can't stretch. So let us look at uh, conditions that can be associated with restrictive lung disease. So we have about 4 spectrum, but the one we are going to be focusing with respect to our lecture is interstitial lung disease. So 4 of them, the alveoli problems. So you look at the micro unit of the lung, that's the alveoli. You look at the tissue that is surrounding the alveoli, that's the interstitial space, because you have tissue surrounding the alveoli, that's the interstitial space. Then you look at the chest wall itself, that's the bone, and the muscles and nerves. So pathologies can occur in any of these 4 aspects, leading to restrictive lung disease. So for the first one, which is the alveolar level, you can have fluid in the alveoli from maybe acute respiratory distress, from pneumonia. Blood might fill the alveoli from hemorrhage from maybe granulomatosis, polyangiitis, Wegener's, or somebody that has Goodpasture disease. They can have bleeding into the alveoli, and that alveoli will not be able to stretch. It will not be able to take more things. So it will give a restrictive pattern in a way. You can have pus too, filling up the alveoli. It's going to make that lung restrictive because it cannot expand. So that can also occur in setting of pneumonia. But the alveolar stuff is not commonly tested. Then the next one is, okay, problems with the tissue surrounding the alveoli, that's the interstitium of the lungs, most of the time they can get fibrosed. And when they are fibrotic, they cannot stretch. They are not compliant. So, what are those things that can cause um, interstitial lung disease? You have idiopathic pulmonary fibrosis, in which you have fibrosis of the lung without any identifiable cause. So, most of these pulmonary fibrosis stuff are actually with a pattern, an histology pattern that you call usual interstitial pneumonia. So, I'm going to talk about this usual interstitial pneumonia when I get to idiopathic pulmonary fibrosis. So, it's more like an histologic finding. It's very common in people that has idiopathic pulmonary fibrosis. Um, Non-specific intestinal pneumonia, chronic hypersensitivity pneumonitis, sarcoidosis, all these conditions can cause fibrosis of the lung tissue, and we are going to look at them one by one. So we can have problem with the nerve and the muscles that controls the respiratory mechanics. So how we breathe in and breathe out. If there's a problem with the muscles, you cannot, and we remember that we even need the muscles more during inspiration to take in air. So if there's paralysis of the muscles, the intercostal muscles, the diaphragm, from any reason, the person will not be able to expand the chest to bring in air. So in a way, the lungs will be restricted. They will not be able to expand. So we can break it down into the muscular aspect and the nerves aspect. So for the muscular, I can talk about things like autoimmune disease like myasthenia gravis that we know is associated with muscular paralysis. We can talk about ALS, we can talk about um, Lambert-Eaton, we can talk about Guillain-Barré for the, you know, for the nerve animals. Then for the nerves only, you can talk about trauma to the nerves like French nerve palsy, maybe from trauma, maybe from cancer. So the pancreas tumor can compress of the phrenic nerve and it can lead to French nerve palsy, leading to paralysis of the diaphragm. And we know that diaphragm is a major inspiratory muscle to bring in air into the lungs. So the person is going to have problem bringing in air, and they will have patterns similar to restrictive lung disease, because people with restrictive lung disease, they can't take in air because the lung cannot expand to receive air. So that's just very similar to what we have in phrenic nerve palsy. The diaphragm is already gone. You cannot contract the diaphragm to generate a negative intercostal pressure to allow air to come in. So it will be as if the person also has a restrictive lung disease pattern. So people with uh, myopathy, from maybe Duchenne muscular dystrophy, polymyositis, dermatomyositis, the respiratory muscles are also paralyzed. So you can look at it from different angle. Maybe the diaphragm, you can look at the intercostals that are supposed to allow for chest expansion to take in air. That doesn't happen. So they have restrictive lung disease pattern. Or it could be the bone, maybe abnormal curvature of the bone. For example, people with kyphoscoliosis, the kypho aspect is talking about excessive C shape of the chest wall. If it's becoming excessively convex, like C-shaped, that can also affect compliance of the chest wall to expand to allow for inspiration to take in air. So when they are not compliant, when they are restricted, you have restrictive lung disease. People with obesity can have fatty infiltration of the muscles, fatty infiltration of the bones, and they don't allow for adequate excutatory expansion of the chest wall to take in air. Restrictive lung disease. People with ascites, so they can have, they can be pushing up the weight, upward on these muscles, so they don't allow for adequate chest expansion because of the fact that they are accumulating, they are not allowing the diaphragm to even come down, generate, negative pressure to bring in air, or they are not even allowing the chest wall to expand very well. Ascites, pregnancy, the same thing. Pregnancy and ascites are like working through similar mechanism. The excessive, upward displacement of the chest wall and preventing, enough space for the chest expansion. People with ankylosing spondylitis too, because you have this costovertebral fusion. Those joints connecting the chest wall to the vertebrae are excessively fused. So you don't have enough room for chest expansion because it's already fused with the vertebrae. So that can also cause restrictive lung disease. So you can look at it from the micro, which is the alveoli, to tissue surrounding the alveoli, interstitial, then to the outside, the chest wall, focusing on the muscles, the nerves, that's how you can, explain, you can have an overview of restrictive lung disease pathology. So now, focusing on interstitial lung disease specifically, they are a heterogeneous group of disorders that are associated with inflammation and fibrosis. So that's the key stuff there. They have this chronic inflammation and fibrosis of the interstitium of the lungs, which is the tissue surrounding the alveoli. So we are not looking at problem with the alveoli now, or problem with the chest wall or the muscles, but the interstitium of the lungs. That is what we are focusing on. And it's also important to know that in advanced disease, that is when the disease is very, very severe, you tend to see honeycombing appearance. So you see a lot of these in questions. Once you see honeycomb pattern on a chest CT, you should be thinking of fibrosis of the lungs from any of these interstitial lung disease pathology that we are going to talk about. So the honeycombing appearance I'm going to show us, I think we are going to see the CT downward. It's just talking about cystic spaces within the airway. So the air spaces are dilated and they are surrounded by thickened fibrotic tissue. So that's what gives this honeycomb pattern on chest CT. So cystic spaces within the lung periphery that are surrounded by thick fibrotic tissue. That is the honeycomb pattern. It signifies advanced pulmonary fibrosis. So, which is a hallmark of interstitial lung disease. You have this widespread inflammation and fibrosis affecting the lungs. So it's also known as diffuse parenchymal lung disease. So you have three subgroups for the interstitial lung disease. The ones that are related to exposure, the ones that are associated with systemic disease or connective tissue disorders, and the ones that are idiopathic. So I remember that in our first aid for step 1, I'm not sure it was classified like this. So this is just for organization's sake so that we can remember a lot of it. So for the exposure, we think about, all these organic and inorganic dusts, asbestosis, silicosis. Remember all those, our pneumoconiosis, they are shared with fibrosis of the lung tissue. So they can cause interstitial lung disease. Still on exposure related, hypersensitivity pneumonitis is a very, very interesting stuff to know. It is also exposure related because it's very common in farmers, in people that, deal with all this bird rearing. So bird fancier disease, people that, um, uh, what's the word now? Farmers that rear cattle. So they get exposed to some of those antigen from these animals. They get exposed to the antigen from the dung. People that rear birds to bird fancier, they can get exposed to the antigen from the bird feathers, the bird dungs. People that make wine, they can get exposed to some molds from the raw material that they use making what they use to make the wine. So, which I'm going to talk some grapes. So we call that wine maker disease. So we have a lot of them, a lot of them. So all of them fall under the class of hypersensitivity pneumonitis. So it's more like exposure to wide range of antigens. Most of them are related to farming. So we're going to talk more about it when we get there. Then people that get exposed to radiation. Radiation can also cause interstitial lung disease, acute and chronic radiation pneumonitis. So at the end of the day, the hallmark of this radiation-induced injury is fibrosis at the end of the day. So exposure to radiation, exposure to some animal products, some bacteria, some molds, they can lead to hypersensitivity pneumonitis, exposure to organic and inorganic dust. Then the ones that are related to systemic disease, so you just think about most of some autoimmune disease like dermatomyositis, polymyositis. So they can cause interstitial lung disease because the inflammatory response, which is autoimmune abnormal, can also get to the lung, leading to fibrosis of the lung. Scleroderma is something we are already familiar with. We know it to be a cause of interstitial fibrosis because the inflammatory response can also affect the lungs, just like in polymyositis and dermatomyositis. Sarcoidosis is another chronic granulomatous disease that is very, very important to know for our exam. In fact, the primary organ that typically affects is the lung. So, and it's actually with fibrosis of the lung. You can have some infiltrative disease too, like amyloidosis. Amyloidosis can affect a wide range of systems: the kidneys, the CNS, peripheral nerve, the liver, the skin, including the lung tissue. So people with vasculitis, you know, they can also have some widespread inflammation affecting the pulmonary vessels spreading to the tissues, you know, in the lungs, like someone that has Wegener's granulomatosis now. It's a form of vasculitis. So the inflammatory response can also extend into the lungs, causing massive pulmonary fibrosis. So that's that about the systemic disease and the connective tissue disease. Then for the idiopathic, so idiopathic, two major stuff to remember under the idiopathic class. Idiopathic pulmonary fibrosis itself and something we call cryptogenic organizing pneumonia. So this used to be called the bronchiolitis obliterans organizing pneumonia as BOOP because it typically affects the smaller airways, which is the bronchioles and the alveoli. That's where you see this guy. We are going to talk more about the two of them as we move. So, key fact: it is important to know that there are some certain medications and interventions that can lead to pulmonary fibrosis causing interstitial lung disease. So, like amiodarone, I think I said band radiation. Band radiation, that's the acronym for the. I know we are very conversant with most of this medication. Now, step one. So, the B is valsartan, bleomycin. Bleomycin, one of those chemotherapeutic agents. Valsartan is also another one. Amiodarone is the A. Nitrofurantoin, which is mostly used for UTIs, is another one. Then, of course, radiation, radiation exposure, just like we have, said part of under the exposure related. Then, long-term high oxygen concentration. Well, some people, you know, they might not know what they are doing and they want to increase the FiO2. Maybe they place somebody on mechanical ventilation and they will think, okay, this SpO2 is low. Let's increase the oxygen concentration. Let's increase FiO2. If you do that, you can tilt that person towards oxygen toxicity, and part of the complication is going to be pulmonary fibrosis at the end of the day because that process is going to generate some free radicals that will lead to inflammation that can eventually cause fibrosis. So, and of course, we know this main guy, methotrexate, to be a very bad guy. Methotrexate can also cause pulmonary fibrosis. So, what is peculiar to people with interstitial lung disease? How do they present? One thing to watch out for is this pattern of presentation. Number one that I want us to take note of is the fact that they get dyspneic on exertion. Like that is a basic sign that we need to know. Dyspnea on exertion. And they experience fatigue from that, of course, and they have this chronic non-productive cough. Just like I said during our microbiology section, when we see cough that is not productive, if it's not if it's not if you are thinking of infection, you know that that is definitely going to be from the atypical guys, maybe mycoplasma, legionella, chlamydia, the likes. That's not where you'll be thinking about strep pneumo or something. But if you have ruled out infection and you see somebody presenting with chronic non-productive, of course you know that that's non-productive cough with dyspnea on exertion. That's a chronic process. So you have to have interstitial lung disease at the back of your mind. And they have a typical pattern of breathing, which is shallow and rapid. So I don't know if I'm going to have time to talk about maybe I should just mention it. So we remember, yeah, in our step one, the formula to calculate for the formula for minute ventilation is the product of tidal volume and respiratory rate. So you can increase minute ventilation by either increasing the tidal volume or increasing maybe I should write it here so that we can see the minute ventilation, equals tidal volume times respiratory rate. So this is a way to increase ventilation for any patient. That's what you can alter. Now, I mentioned something about compliance. I said somebody that has people with interstitial lung disease, their lungs are not compliant. That is, that lung cannot stretch. And I mentioned that it means that the elastic recoil of that lung is high. That's what it means. Because the elastic recoil is a tendency for the lung tissue to come together. Bam! That's it. So what you want to try to do in that kind of situation is to do any intervention that can help you reduce elastic recoil. And one thing, there's another rule again. An increase in the respiratory volume, if you are taking in air into the lungs, you are kind of like trying to stretch it. And that stretching will also want to increase the elastic recoil. That's one thing. So if you take in more volume, the elastic tendency of the lungs will increase. So that is why one of the maneuvers to do in somebody that has restrictive lung disease, where the elastic recoil is high, is to reduce the tidal volume. So, and at the same time, you also want to maintain a balance of the minute ventilation. So, what you do is to drop the tidal volume and increase the respiratory rate. So that is how people with interstitial lung disease manage to survive. So they take rapid, but it is not deep. It's not like, so they take rapid, increase in respiratory rate, but shallow breath. So when it's shallow, the volume that they are taking is small. When it's rapid, the respiratory rate is increased. So in that pattern, they will maintain their minute ventilation, but they will not increase the elastic recoil, and they'll be fine. So the reverse occurs in people with obstructive lung disease. People with obstructive lung disease will not increase their respiratory rate. So they will reduce the respiratory rate and increase the tidal volume to maintain the ventilation. Because if someone that has obstructive disease, they have problem with expiration. So that means that they must do any intervention to make them have a prolonged expiratory rate, to have more time to take out the air during expiration. And it is important for us to remember that if you look at a respiratory cycle, expiration takes more time than inspiration. That is it. So you can look at that maybe from the fact that expiration requires is a passive process, while inspiration is active. So you have some muscle that is helping you to quickly take in air, while expiration is just elastic recoil. So it will definitely take more time than inspiration. So people with obstructive disease, lung disease want their lung to take more time in expiration, and the way they can achieve that is by reducing their respiratory rate. So instead of doing 20 cycles per minute, they would rather do 10 cycles per minute, so that the duration of expiration will be longer, and they'll be able to, clear out that volume that is retained in expiration. And because of the fact that they have dropped their respiratory rate, they will now increase their tidal volume. So that is what those are the changes you can set to your mechanical ventilator to take care of different pathologies. We are going to talk, I'm just trying to introduce us to that concept so that by the time we get to mechanical ventilation, we understand it more. So we have talked about the fact that they are always dyspneic on exertion. They have non-productive cough, which is dry, non-productive cough, dyspnea on exertion, and the breathing pattern is rapid but shallow. You have somebody with this pattern, you are thinking of a restrictive lung disease, particularly interstitial lung disease. So what is the next best step you want to do? The next best step is to order a chest X-ray. And what are you going to see? Reticular nodular pattern. You see reticular, like, crossing. Nodular, like small nodules, or a ground glass pattern. So ground glass pattern is typically seen at early phase of fibrosis, just like I have it. So when the fibrosis is early, what you are going to see is ground glass opacities. But when it is late, you are going to see the honeycombing that I mentioned initially. Honeycombing is seen in advanced late interstitial lung disease. But when it's early, you see the ground glass pattern, which is just talking about accumulation of chronic inflammatory exudate and debris. That is it. So don't forget, reticulonodular pattern on your chest X-ray. You are definitely dealing with a form of interstitial lung disease and the chronic, the ground glass opacities. So the next best step is to do a CT to confirm your diagnosis. That is what you do. You don't stop at X-ray and you make your conclusion and you start treating. You do your chest X-ray, you conclude with your CT, which is a high resolution CT. That's what you do. Once you have a high suspicion for interstitial lung disease, you move forward to do your high resolution CT scan. And what are you going to see? Your CT scan, when it's advanced, you are going to see the honeycomb pattern, which we have talked about. So you can now further, to make your to marry all those things together to make sure that, okay, this thing is in keeping with what I'm thinking. You can do your pulmonary function test, definitely, to be able to assess the functional capacity of the lungs. How's it doing? How bad is it? And what do you expect in a restrictive pattern? I've said it that restrictive lung disease, they have already taken in air, and if they can't take in air initially, they don't have any air to take out. So all the volumes reduces. Everything, FEV1, FVC, TLC, RC, everything drops. Everything is zero. So not zero literally, just saying it drops. The only thing that increases is your FEV1 over your FVC ratio. That's the only thing that increases because your vital capacity drops more than your FEV1. I said it that in obstructive lung disease, FEV1 drops more than FVC, but in restrictive lung disease, FVC drops more than FEV1. That's why you can actually have that ratio more than 70% in there. So it can be normal when you have equal drop in FEV1 and FVC, it will be normal, or it is increased. It is never less than 70 in restrictive lung disease. Please, you have to know this. It can be normal or increased. So many people remember the increased part, but they forget the normal part. It can be normal. It can be normal. So we should not forget that. So we have talked about the fact that you can have your FVC drop, your FEV1, drop, and sometimes your FVC may be also normal. That is, with respect to your FEV1, it's normal with respect to your VC1. So yeah, so that's that. But I'm not, making it. Yeah. Okay, no. That should be for FV1. Sorry, yeah, that's a mistake. I'm so sorry. I know what I said was wrong. So you can have your FEV1 normal. So that means that in that situation, your FVC is lower than your FEV1. So that's why the ratio will be increased. Let me come again what I'm saying. FVC can drop, FEV can drop. But in some situation, you can have your FEV1 to be normal. So when your FEV1 is normal, it means that your FVC definitely is lower than your FEV1. So in that kind of situation, you are going to have an increased FEV1 FVC ratio. So please, do we understand that? Hope I've corrected myself very well. Please, do we get it?
I didn't get it.
Okay. I said that the FEV1 FVC ratio can either be normal or increased, right? So if the this ratio, sorry, I don't want to be stressing myself pronouncing them individually. If the
Okay.
ratio is normal, it means that both FVC and FEV1 dropped equally, right? That's why it is normal. They dropped equally.
Okay.
But I said in some instances, you notice that your FVC will drop more than your FEV1. So that instance is when your FEV1 is normal.
Okay.
So if your FEV1 is normal, it means that your FVC is lesser than your FEV1. So if you calculate the ratio, so for example, if it's let's say it's initially is 10 over 10, 10 over 10. The ratio for 10 over 10 is 1. But if you're and let's say that okay uh 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 the normal value for FEV1 should be like 20. So let me say 20 because now normal for FEV1 should be 20, normal for FVC let's say maybe 22. Yeah. So 20 is the normal for FEV1, 20 is the normal for FVC. Now both of them dropped equally by 10.
Mm-hmm.
When you calculate the ratio, it gave you 1. So it means that the pattern is normal, the ratio is normal, right? So,
Yes.
and this is still in keeping with what you have in restrictive lung disease. But you can have some situation in which um, your FEV1 will be normal, which is 20, and you have
Mm-hmm.
your FEV dropping. Let's
FVC.
say it drops to like 15 or 10. If you calculate
Okay.
that ratio, it will be higher than 1. So that ratio
Yes.
now, let's say it drops, that's like 2. Share again.
Okay.
So
Yeah.
you might not need to cram or know all these things. Just have it at the back of your mind that
Yeah, I understood. So in instance where the FEV1 is a little bit higher than FVC, it will not give you a ratio, an increased ratio, kind of.
exactly. So,
Okay.
but you know that you can't have increased FEV1 in restrictive lung disease.
I know.
It cannot be increased more than normal.
It cannot be increased, but at least the FVC
Relatively,
dropped more than FEV1
relatively,
relative.
exactly.
Yeah.
So relatively, compared to the FVC, it will be higher than it. So, and of course, the other ones will drop. Your total lung capacity will drop. Your FVC drops. Your TCLO will definitely drop because TCLO usually drops in any pathology that affect the lungs. Once you have taken out lung problem, once you identify that the lung is gone, DSLO is gone. So that would differentiate interstitial lung disease from the other forms of restrictive lung disease. So you don't expect DLCO to drop in someone that has neuromuscular problem because the lung is not affected. The lung tissue itself is not affected. Thoracic wall problem, kyphoscoliosis, obesity, the lung tissue itself is not affected. So DLCO will not drop. But DLCO might drop when somebody have alveolar edema, hemorrhage, and the likes, and interstitial lung disease because they are affecting the lung parenchyma. So DLCO is a very, very important clincher to look at in the question so that to narrow down the answer for us. So, what are the other investigations to do? You have identified the classic pattern of restrictive of interstitial lung disease on your X-ray, the reticulonodular or the GGO, the ground glass opacity. You do your next best step, which is your high resolution CT scan, and you can also see the ground glass opacity or you see the honeycomb beam pattern. When it's advanced, then you can now do your pulmonary function test, to see what you are dealing with, the severity. So you can either see a normal ratio or increased ratio. Then you can now do other workup to narrow down the cause of that interstitial lung disease. We have said three things: either exposure, Is the person exposed to radiation from, treatment for cancer? The person is working in a farm, develop exposure to some antigens and the likes, or maybe the person is working in a construction company, develop exposure to asbestos. You rule that out. You look at systemic. You check for all those autoantibodies. Somebody having sclerosis, systemic sclerosis, CREST syndrome. You want to assay for your anti-centromere antibody. Somebody having polymyositis. You want to do your JOAN, your helicase antibody, because it can also be caused by other autoimmune disease that we do not mention, like rheumatoid arthritis. You want to check for your anti-citrullinated peptide, rheumatoid factor, SLE. You want to check for your HANA. Your antibody result will also give you, what you are likely dealing with. Then the last one is the idiopathic. So idiopathic, you will not be able to find any cause. So that's when you can now put your diagnosis to be on that category. You do your antibody panel, you took history and everything, you couldn't find an identifiable cause, that you can now say your cause of your testicular lung disease is idiopathic. So that's the way it works. So the most accurate test, so this is not the best next step now, but the most accurate that you can use to beat your chest that this is what I am dealing with, is by doing a surgical biopsy. But you don't need it. It doesn't usually get to the level of surgical biopsy. Your CT is usually enough. So it's only done when your CT findings are not characteristic. So you are not seeing your opacities, you are not seeing the reticular opacity, you are not seeing the honeycombing. Then you can now do a surgical biopsy and look at the histology picture. So here now we can see the honeycombing. We can see here, this area now, we can see this airway surrounded by this whitish stuff. So that's the area of fibrosis surrounding the cystic hair spaces. So all these parts everywhere, down like that. So that is we are still going to check for a clearer image. So this is histology finding. You don't need to know the histology finding. They will not show you histology, but you need to know the CT appearance. So how do you treat? So this is just general treatment. So anything that is causing it, maybe exposure related, you want to avoid exposure to anything that is causing it. Asbestos, silicosis, anything. Avoid exposure. Then in some situations, you might want to give medications. So some of them require medication. People with sarcoidosis, you might want to give them medication. People with hypersensitivity, pneumonitis that is chronic, you might want to give them medication. Don't worry about it. We are going to talk about them. So this is just like a general overview. And in some particular set of people, that is people with the idiopathic pulmonary fibrosis, you give them antifibrotic agents. So that's the class particularly that you use antifibrotic agent. You don't use antifibrotic in all of them. So you use antifibrotic primarily in people with idiopathic pulmonary fibrosis. So your antifibrotic agent is going to suppress production of your transforming growth factor beta, and it will, prevent activation of fibroblasts that lay down collagen. So the way I remember them is to remember Perfect and Nintendo. So Nintendani and Perfenidone. So Perfenidone and Nintendani. By the time you look at it one or two times, it will register in your head, and when you see it in questions, you'll be able to know what they are talking about. That is even if they give you the drug. Most of the time, they will just say antifibrotic agent. USMLE is not that wicked. They don't expect us to be cramming names of medication, but it's good to be familiar with them. So if it has gotten worse and it's not responding to your medications, you might want to refer for surgery to do a lung transplantation, particularly people with that having serious complications. You have to refer them for surgery. So moving on to each of those interstitial lung disease, the first we are looking at is the cryptogenic organizing pneumonia. So let's just forget about this big name. The word cryptogenic means you don't know the cause. Organizing pneumonia, you're having granulation tissue being formed, in the lung. That is just the stuff. So the pneumonia there is because they have this pneumonia-like presentation. So in this disease, generally, you just have formation of granulation tissue, which you call the Mason body. MA, I think I should have it here. So So the missing body, yeah, I know I have it. So the missing body is just aggregate of fibroblasts, fibrin, with deposits within the lower respiratory tract. That is the respiratory unit, the alveoli duct, and the bronchioles. So that's why it's initially been called bronchiolitis obliterans organizing pneumonia, BOOP. Bronchiolitis obliterans organizing pneumonia, because you have this granulation tissue being deposited within the alveoli duct and the bronchioles. So we just have to focus on the clean charts for this diagnosis. So from the word pneumonia, so this person is going to have a pneumonia-like picture, but don't forget this is a chronic disease process. So the person is going to have, like subacute fever. So fever that lasts more than 7 days, ranging between 7 to 14 days. Subacute fever. And the person is going to have other features of pneumonia, which includes cough. That's going to be dry because it's not infectious. So dry cough, dyspnea, shortness of breath, weight loss because it's chronic. So cough, dyspnea, weight loss, and fever. That's what is peculiar to cryptogenic organizing pneumonia. So anytime you see this guy, just know it that okay, cryptogenic, no cause, we don't know. Organizing, you have granulation tissue, where within the respiratory units, the alveoli ducts, and the bronchioles, and the pneumonia. They are going to have a pneumonia-like presentation, which is fever, which is dry cough because it's non-infectious, dyspnea, and because of the fact that it's a chronic stuff, is going to cause weight loss. So once you have that, okay, you're on your way. Then, and most importantly, we not to respond to antibiotics, because if you have someone that has this kind of pneumonia-like picture, cough, fever, you want to test, with your antibiotics. You notice that you give your antibiotics, it's not responding. You think about this. You think about this. So it doesn't respond to antibiotics. The only thing it responds to is steroids. In fact, once you see the question stem talking about somebody having, subacute chronic pneumonia-like presentation, failed to respond to antibiotics, but responded drastically to steroid. The response is sharp. In fact, you see improvement almost like within few days of starting your steroid, few hours to few days of starting your steroid, to raise suspicion for cryptogenic organizing pneumonia. So this is a diagnosis of exclusion. You will have definitely ruled out infection and all those autoimmune diseases like your RA, your SLE, and like you have your scleroderma. You will have ruled them out. You will have done your bronchoalveolar lavage, because it will be very difficult to be using sputum in someone that is having non-infectious process. So you might want to go in, do your bronchoalveolar washout, and as a check for infection. It will definitely be negative. So that is part of what you are going to notice. And at the end of the day, if you do your imaging, which is your chest X-ray or your CT, importantly, you are going to see bilateral, peripheral, patchy opacity that migrate. Very, very important stuff. You are seeing one now. When you repeat it again, you see it in another section. You repeat it again, you see it in another part. Migrating. The opacity is area of fibrosis. They are kind of migrating from one part to another part. It's very classical for cryptogenic organizing pneumonia. Amiodarone too can, do that in a way. It migrates to in amiodarone, but definitely in amiodarone, you are going to get history of exposure to that drug in your question. So you cannot say it is idiopathic again. So that's why you might not, just say that, okay, once you see migratory, you just assume that it's cryptogenic. No, you have ruled out other potential cause. So once you see amiodarone with the questions then, and they are talking about opacity in the middle lower lung zone that's migratory, sometimes it can also be from amiodarone. So of course, because of the fibrosis and the opacity that it has on the lung tissue, it's going to lead to a restrictive lung pattern. And of course, because the lung tissue is affected, it's going to affect the respiratory membrane. There will be reduction in diffusion impairment. And what parameter are we going to use to know that there is problem with diffusion impairment? Anybody?
DLCO.
Our DLCO.
DLCO.
So that's it. So how you can definitely know your diagnosis and accurately is when you now do your surgical biopsy. So just watch out for the word accurate diagnosis, or the most diagnostic investigation to do. It is your surgical biopsy. So you are going to see all this granulation tissue, your Manson body, fibrin, fibroblast collection within the alveoli and the alveoli ducts. That is it. So you can do that surgically, in which the surgeon makes a small hole in the chest, obtain a small section of the lung, or you go in through your bronchoscope and do a biopsy from there. So treatment is with steroid. Don't forget, it has a dramatic, look at that word, a dramatic clinical, so and radiologic response to steroids. And the person can relapse when you taper down on the steroids. But overall, the prognosis is very good. So don't forget, get history of someone that has pneumonia-like picture. You start antibiotics, no improvement. You start your steroids, there's improvement. You do your imaging, you see your bilateral peripheral opacity that migrates. You think about, and you have ruled out other pathologies. You think about cryptogenic organizing pneumonia. So sarcoidosis is another stuff to know.
Sorry, Dr. Babawa. Uh, sorry.
Hello.
So, yeah, sorry. So, what features do you see in pathology?
Yes. So I've said it. I said you are going to see these loose connective tissue plugs containing the Mason body. So aggregate of fibrin, fibroblasts.
Hold
You know,
on. Put this down. You said aggregate of fibrin.
yes, fibrin, fibroblasts. You know, within the alveoli duct, and the bronchioles. So
Okay.
that's what you are going to see on histology. So
So, is that what you call the Mason body?
yes, that's the Mason body. The Mason body.
Can I see that or something again? Sorry. You pointed it out. Okay. Loose connective tissue plus. Okay. Alrighty.
Okay, so systemic sarcoidosis. Sarcoidosis is one of those chronic granulomatous disease that's very common. So just to talk a little bit about the pathophysiology, it's been believed that there's inhalation of environmental foreign antigen, being taken up by the lung antibodies. No, sorry, I said lung antibody. The lung antigen presenting cells, macrophages, dendritic cells, they take it up, they go to the lymph nodes, the neighboring lymph nodes, and they release interleukin 12. And we remember from immunology what interleukin 12 does. Interleukin 12 will convert the naive T cells and it will make them differentiate along the pattern of the TFR1. TFR1 will release gamma interferon that is going to activate the macrophage, converting them to, the epithelioid cells and the likes. Then the inflammatory response will kick up. So your TFR1, your activated macrophages, they are going to form granuloma around that foreign antigen, which we don't know because the cause of sarcoidosis is not known. But what is peculiar to sarcoidosis is that you notice accumulation of non-caseating. We remember from our microbiology, when we see non-caseating granuloma, we don't think about infectious process because if it's caseating, that means you can be thinking about TB, you can be thinking about histoplasmosis, you can be thinking about leprosy. But once it is non-caseating, it means that it is not from infectious pathology. That's a way to code it, right? So, which is very typical for systemic sarcoidosis because we don't have any infection that is causing this. So, we have these granulomas depositing in almost all the tissue in the body. That is why we call it systemic sarcoidosis. It can affect myriad of tissue in the body. Apart for it, epidemiology, it is very common in females within their third to 40 decade of life. So females within 30 to 40 years, particularly of African descent or Northern European descent. Very important stuff. So that's why if they paint a picture of someone that has sarcoidosis, and they ask you what is the risk factor for this condition, if you see ethnicity in the question stem, you are picking it. You are picking it because it's common in people Northern European descent and African descent. So, um, I've just given us a little intro about how the pathophysiology occur. And one thing to know is that this condition typically affect the lungs. The lungs is the primary tissue that is most commonly affected in sarcoidosis. And we need to know the pattern of presentation. Most of the time, they have bilateral hilar adenopathy. So you just notice enlargement of the hilar lymph node, bilateral enlargement of the hilar lymph node. You must always consider sarcoidosis. Most of the time, that finding is even incidental. The person might be asymptomatic. So it can be an incidental finding, the bilateral hilar adenopathy. And sometimes you can have some symptoms, which include fever. So don't forget, fever is in cryptogenic organizing pneumonia. Fever is in sarcoidosis. Because it affects the lungs, they can start coughing. And the cough is also going to be dry. They can be dyspneic. They can have other constitutive features of chronic inflammation, which is, malaise, weight loss, especially. There's a syndrome that we need to know. Me, I don't really encourage people to be palming syndrome, but there are some certain syndromes that you need to know because they are very classic for some certain disease, like sarcoidosis. Lofgren syndrome. The reason why this syndrome is important is that the component of this syndrome is what they usually put in the question stem to nail diagnosis of sarcoidosis. You just see them talking about FAME, in which F is the fever, A standing for the adenopathy, M is standing for the migratory polyarthralgia, and E is talking about the erythema nodosum. So FAME, fever, adenopathy, migratory arthralgia, or you can delete the M if you don't, just replace it A, that's arthritis, adenopathy, and E for the erythema nodosum. So most of the time, you see them talking about somebody having tender nodular lesion in the anterior aspect of the leg, particularly the shin. Once you see that, that is erythema nodosum. Erythema nodosum rash is very classic. You cannot miss it. Once you see it, you can never miss it. Like it's a very classic, rash pattern. Sarcoidosis should come to mind. See somebody having this kind of bumpy, rash in the chin, and it's very tender. You touch it, it's tender. So once you see this is sarcoidosis. So if it's not infectious, so if it's infectious, you can think about mycoplasma, herpes simplex, mycoplasma. They can also cause erythema nodosum. So um, so now the FAME, the fever, the adenopathy, the migratory polyarthralgia, and the erythema nodosum. So that's the Lofgren syndrome. And this syndrome has a good prognosis. In fact, anybody that has this syndrome, just give the person NSAID. The person is going to be fine. So there's a question here. A 25-year-old black woman presents to the physician office with painful bumps on her shins, weight loss, and cough. Examination reveals a prominent 1 centimeter right axillary lymph node. What's the next best step? So I have not talked about the investigation modality, but we'll be able to answer the question as we move. So what are the extrapulmonary manifestations? So what I'm going to say is that outside the lungs, the most commonly affected, structure is a lymph node. So they have lymphadenopathy. And where is this site of lymphadenopathy? Usually hilar lymphadenopathy. They can have it other regions too. They talk about the skin. Okay, let me just go as it's ordered here. So the liver. So you can have the granulomas forming in the liver. And when this granuloma forms in the liver, it can lead to hepatitis, can lead to hepatomegaly. So they will tell you the person has hepatomegaly. It's not unusual. They can have the granulation tissue affecting the eyes, so uveitis. So they have anterior and posterior uveitis. But anterior uveitis is common. So for anterior uveitis, you see the patient presenting with eye pain, redness, photophobia. So somebody having eye pain, redness, photophobia, and you are seeing this sarcoidosis like of presentation, that is likely to be the uveitis. Anterior. For the posterior, they have more floaters in the eye, but I don't think we need to worry ourselves about posterior. Most of the time, anterior uveitis is what they talk about. Then the skin. The skin, they have the erythema nodosum that we have talked about. They have some purple colored plaques. And then something they also have in the face that we call lupus pernicious. So they have this lupus-like of type of rash, lupus-like rash on their face, just exactly like lupus. It's very common. We call that lupus pernio. Lupus pernio in people with sarcoidosis. They can have problem with the CNS. And what I want us to remember with respect to the CNS is facial nerve palsy. That's the number one thing to remember. They can have a problem with the maybe when we think about the nervous system rather. So facial nerve palsy should come to our mind first. Facial nerve palsy. Facial nerve palsy. Is very common in people with sarcoidosis. And I'm going to also expose us to another triad, the Edford triad or the Edford syndrome is another thing, that's associated with this facial nerve blah blah with it. You can have the granuloma forming within the pituitary gland, leading to hypopituitarism. Um, People with sarcoidosis can have, from our pathology, we remember that they have upregulation of alpha 1 hydroxylase from the epithelioid cells, and that is going to increase vitamin D production, and vitamin D is going to elevate the calcium. So they can have a widespread calcium deposit in the body, leading to calcinosis in vessels. You can have calcium deposit in the kidneys, so causing nephrocalcinosis, right? You can have the granulomas in the lungs, in the heart rather, so it can cause cardiomyopathy. Classic. Sarcoidosis is one of the common causes of restrictive cardiomyopathy. So, and most of the time it causes arrhythmias or heart blocks, second, third degree heart blocks, arrhythmia, cardiomyopathy. So, it can also affect the pericardium, leading to pericarditis. It can cause problems with the kidneys, which I've talked about, nephrocalcinosis, the acute interstitial nephritis, the CNS, hypopituitarism, facial nerve palsy. A lot. Just think about any organ, the joint, migrating polyarthralgia, the eyes, uveitis, the liver, the kidneys, the skin. And we should not forget about the vitamin D that is elevated, causing the calcinosis. We should not also forget the ratio of the CD4 plus to CD4 to CD8 that is elevated. Because from the pathophysiology that I described, the antigen presenting cells will definitely activate the TFR1. TFR1 as CD4 cells. So that's why the CD4 CD8 ratio is usually elevated. So, what is the best initial test that you want to do in an individual with sarcoidosis? You want to do a chest X-ray, looking out for what? The bilateral hilar adenopathy. That's the first thing. And of course, the reticular opacity, which is very common in the upper lobe. So they have this reticular opacity, and of course, with the bilateral hilar adenopathy in the upper lobe of the lungs. So just like other interstitial lung disease, so once you see a suspicious chest X-ray, you want to confirm with your high resolution CT scan. And you are going to see almost the same thing again, but clear view now. You are going to see the reticulonodular opacity in the upper lobe and your bilateral hilar opacity, bilateral hilar adenopathy. So reticulonodular opacity, which indicates fibrosis within the upper lobe of the lungs, and your bilateral hilar adenopathy. So once you see this is the bilateral hilar adenopathy, and you look at the clinical history, you should consider diagnosis of pulmonary sarcoidosis. So after your suspicious CT, the next thing to do is to do a biopsy. So you do a bronchoscopic biopsy, or if the person doesn't have any pulmonary manifestation, if it's just maybe only skin or only lung or only lymph node, you biopsy that site. You biopsy that site and you look at it on histology. And what you are going to see is the non-scintillating granuloma. So you marry that granuloma presentation with whatever you are seeing, because there are so many things that can cause non-scintillating granuloma. So you see somebody with non-scintillating granuloma on biopsy having bilateral hilar adenopathy. That is not the time to be thinking about berylliosis. Like, okay, maybe berylliosis too can cause non-scintillating granuloma, but will it cause bilateral hilar adenopathy? Will it cause erythema nodosum? No. So you have to make your diagnosis with your biopsy feature, combining it with a compatible clinical picture. So that is how you make diagnosis of sarcoidosis. Non-scintillating granuloma is what you are looking out for, your biopsy, and the necessary clinical history, which we have talked about. The skin lesions, the high lesions, what else again? Depending on the organ that is affected, you can make your diagnosis. So pulmonary function test definitely is going to show the restrictive pattern, because it can cause fibrosis of the lungs. So it's going to be restrictive, they cannot expand. And because of the fact that it is the lung that is affected, DLCO2 will be reduced. So this is just like a summary of everything: the granulomas, non-scintillating, the migratory arthritis, the uveitis, the erythema nodosum, the lymphadenopathy, which is bilateral hilar lymphadenopathy, the interstitial fibrosis of the lung, which is what is causing the reticulonodular opacity in the upper lobe. Yeah, and because of the fact that people with TB can have similar presentation, the fever, the cough, the weight loss, people with TB can have erythema nodosum too, but they will not have non-scintillating granuloma. So you might want to raise suspicion for TB, so you might want to do your TB test, and when you do it, it should definitely be negative. And they have hyper gamma globulinemia. So because of the elevated activation of the CD4, they can also activate the B lymphocyte. B lymphocyte to produce more plasma cells producing more antibodies. So you have gamma globulinemia in people with sarcoidosis. So these are the other findings. The ACE enzyme. So this ACE enzyme is part of the laboratory finding. It's going to be elevated because they are secreted by the epithelioid cells. They are secreted by the epithelial cell, but it's not sensitive or specific. There are so many things that can cause elevation of ACE, outside sarcoidosis. So hypercalcemia is another thing, which is a consequence of the elevated vitamin D. Hypercalciuria is a consequence of the hypercalcemia. When it affects the liver, it can elevate alkaline phosphatase. You can also see elevation of other liver markers, AST, ALT. It can suppress the bone marrow, leading to lymphopenia at the end of the day. Cranial nerve defect, which is what? Which cranial nerve are we talking about here? Anybody?
7. Facial nerve.
Facial nerve. Arrhythmias, when you have the granulomas in the heart, they can have arrhythmias, they can have heart blocks. So how do you treat? Many people don't know this, but you don't do anything. In somebody with sarcoidosis, you just observe when the person is asymptomatic. Even if you detect your bilateral hilar adenopathy on X-ray, you don't go and treat unless the person is symptomatic. That's when you now start with steroids. And when do you treat? When the person is symptomatic, the person is having cough, difficulty in breathing, and those, you might want to treat. Or the person is having other and that respiratory stuff is kind of deteriorating. So person is having difficulty in breathing, respiratory failure. You might want to give the corticosteroids, or the person is having constitutional symptoms like fever, like weight loss, you can also give steroid in that kind of person, or any other extrathoracic manifestation. So, facial nerve palsy, having maybe acute intestinal nephritis, nephrocalcinosis, you definitely want to suppress that inflammatory process to take care of that patient. But in any condition where the person is not responding to the corticosteroid, you must give DMAT. DMAT, that's what you use. You use your DMAT. So, and the typical ones, methotrexate, azathioprine, and the biologics, which is the I think I wrote the acronym here to be MAT. Don't know why the stuff escaped MAT. So, methotrexate, azathioprine, and TNF alpha inhibitor. So when you remember the DMAT, just this agent, that's what you use for refractory disease. So love-Grange syndrome, just like I said, good prognosis, fame, zacronine, fever, adenopathy, migrating polyarthralgia, and the E for the erythema nodosum. And there's something called the Edford syndrome. So Edford syndrome is also known as uveal parotid fever. Uveal parotid fever. Uveal parotid fever with facial nerve palsy. So everything about this syndrome is in the head. So for the eyes, they have uveitis, which is part of the presentation in people with sarcoidosis. They have this eye pain, redness, photophobia. You notice that the parotid gland is swollen. So the question stem can give you that the person is having parotid gland, swelling within the chin, the cheek, parotid gland swelling, eye problem, fever, and of course facial nerve palsy. So fever from the neck, person is hot, facial nerve palsy in the face, parotid from swelling from the cheek, and uveitis from the eye. Everything is in the head. Edford syndrome is also, classic for sarcoidosis. So, moving on to
Dr. Baba, I have a question. I'm looking at the symptoms of, like the general symptoms of sarcoidosis and the bronchiolitis obliterans.
The what?
The symptoms of sarcoidosis and with the cryptogenic organizing pneumonia.
Okay. So what did you notice?
That's in fever, cough. The only difference is the shortness of breath, which these ones can also have dyspnea.
Yeah.
So different. So if they put it in an exam, the only way I feel that can differentiate it with these symptoms in both now is the rapid response to steroids.
Yeah. So most of the time, if they want you to, pick sarcoidosis, they will give you the clean charts for sarcoidosis.
Check it out. Okay.
There are a lot of them. Erythema nodosum, parotitis,
the
adenopathy. You will see it. It's not something that you even need to overthink. It's classic.
I know. Yeah, I'm talking about like in the other one. Like I think they paint you a picture of cryptogenic as pneumonia.
In the cryptogenic, they will not give you all these things. They will just tell you that the person is having the fever, the cough, the dry cough, the weight loss, and they give antibiotic, it will not respond.
Okay.
Do you get it? Even if you do your X-ray, you are not going to see bilateral adenopathy because they might talk about the X-ray. So they can tell you that they notice presence of the patchy, peripheral, bilateral opacity, which is migratory. So you see. So
apart from the migratory listing, apart from that migratory something, I'm also thinking towards that cryptogenic. I'm thinking towards this. It's very close to atypical pneumonia too, right? Is it?
Yeah. So people with atypical pneumonia too can have patchy opacities, but it will not be migratory.
Apart from the migratory.
So, but you can have dry cough. They can have dry cough too. They can have, very indolent cause. Their fever is not high grade. All those kind of things. So, but cryptogenic organizing pneumonia is a diagnosis of exclusion. You will have ruled out all those things that they will give. They will not give you anything that can make you nail another diagnosis.
And even that atypical, they can say it failed to respond to antibiotics to Abi.
Yes,
depending on
yes. That's the giveaway. Yeah, and the migratory patchy opacity.
opacity. Yeah, and when they do the biopsy, that is what they saw. So, you know, they will see the Mason body, which is the aggregate of fibrin, fibroblast, in the granuloma. You will not see that in someone that has interstitial pneumonia. So most of the time in interstitial pneumonia, you find out the cause. Maybe they will tell you that the person is young, confined in military barrack, you're suppressing mycoplasma, and the person has erythema nodosum, mycoplasma. Or the person is on immunosuppressive, the person is taking glucocorticoid, and the person has that kind of bilateral interstitial opacity. What's the diagnosis in that situation? Who knows? Anybody?
Dr. Bawale, can you repeat the conditions again? Sorry.
So somebody is on immunosteroids,
Mhm.
immunosuppressive drug, glucocorticoids, and the person developed sudden onset, no, not sudden onset, so like over some days, fever, low grade, non-productive cough, chest pain, and you did your X-ray, you see bilateral interstitial opacity. What is the most likely cause of that?
Sarcoidosis.
No,
Sarcoid. It's
no.
not. It's a bilateral
I did not say hilar adenopathy. I said bilateral
Oh,
interstitial.
bilateral. Okay, not
You know,
hilar.
in
Okay.
somebody that is on immunosuppressive,
Mhm.
and the person is having
TB.
no, my people, I want us to think outside what we are doing,
Mhm.
because you are the people that started it, that say, okay, how do we identify all that thing? So I'm trying to
Yes.
create on that.
Uh-huh.
So somebody is having immunosuppression. There's background
Mhm.
immunosuppression. You have identified in the question step. The person has fever. The fever is not high grade, low grade over some days.
Could it be
Non-productive.
Viral pneumonia.
No.
TB?
TB.
Who said? Someone said something.
Tuberculosis.
Hello?
Is it TB?
No.
I want to
Bilateral interstitial pneumonia. No, I said bilateral interstitial opacity. I don't want to tell us further investigation because I will have helped you. But you should
So atypical pneumonia. No?
It's an
Oh,
atypical pneumonia, but which one?
Cryptogenic.
No, somebody is having fever,
Uh-huh.
difficulty in breathing, immunosuppression with bilateral interstitial opacity. My
Okay.
people.
I know this thing. This what is this thing? But it's an atypical pneumonia caused by viral something.
It's not viral. It's not viral.
Really?
What?
If it's fungal, which one is it?
Okay, fungi. Pneumocystis, Jare.
Oh
Pneumocystis.
my God.
PCP, Abi.
There is background immunosuppression.
Oh,
background immunosuppression.
Is it not Giroveshi?
PCP now.
PCP is a spot diagnosis. Bilateral.
Of course, it is actually.
Dr. Bawale, that's not a little bit even USMLE will not do this to us.
No. No, Dr. Olushola, is that not fair? Is that not fair? That question was fair.
It's fair. There's no way I will see it in option. I won't know it.
That is it. I know that we will get it. The thing is, if I had given option, we would definitely get it. So
you'll be able to rule out.
You'll be able to rule out. But that's just the way.
Is it not reticulonodular in PCP? Is bilateral reticulonodular, or is it ground-glass appearance?
It's ground-glass appearance. Ground-glass appearance, but it's still, a form of bilateral interstitial opacity, because your opacity is within, surrounding the lung tissue, the alveolar tissue. So it's interstitial. So that's the point.
Dr. Bawale, the TB that we are talking about, this immunosuppression, it is TNF alpha.
Let me tell you the reason why.
Why is it TNF alpha? That TB. it can aggravate TB pathogenesis or something like that.
Yes.
If somebody has immunosuppression, you are taking TB, my people. Do you think that X-ray will be showing bilateral?
No, it wouldn't.
No. Where will it be? Where will it be? Anybody, please.
Epica.
That is it. We cannot be thinking TB and be.
Well, no, I think what Dr. Lishola was asking, like if you're giving TNFA alpha, TNF alpha, or whatever, normally you screen them for TB
Yeah.
because you can reactivate TB. That I think that's what he's
Yeah,
asking.
yeah, that's what I
Yeah.
was
So,
saying.
The
so Dr.
reactivation
Antonia,
of
very good one. So, if
Mm.
somebody is on TNF alpha and the person develops TB, where do you think that TB will be?
it will still be in the upper.
Oh, the upper lobe.
Because a secondary TB, it will always be in the upper lobe.
No, the primary should be in the lower part.
Yes. So that's it. USMLE will not give you something that is very complex, and everything works with the
Was
algorithm we have been talking about.
Your own was complex.
So Dr. Jerry, well, don't worry, it's because I just did not put the option. Maybe next time I'll put in option. Maybe that's the only thing that I can say that made it a little bit hard.
So don't put option, Joe. Don't put
Yeah. So,
Option.
so Dr. Babawale, so in cryptogenic, the chest X-ray and the CT findings are the same. They still show you the bilateral migratory peripheral opacities.
Yes, that's very correct. That's
So
very
do you do the two at the same time, or do you need to do one? I
No,
mean,
you do
do
one.
chest.
You do,
So this is
no, you
either
not do,
one.
you
Either
know, the one will follow another. Your CT will always follow
Okay.
your chest X-ray.
Okay.
So you know that the reason why they are doing it like that is that so that you not be wasting money, because
Yes.
CT is expensive. CT involves radiation exposure. So you might not need that CT, So what you do is that first do chest X-ray. Does this person now have symptoms suggestive of interstitial lung disease that is severe? Now do your CT.
Yeah.
It's not that you just start with CT. What if that person doesn't have interstitial lung disease? You just expose the person to radiation. So that's where it is. That's where it is. Don't worry, I'll ask another question, I'll put option there. So I'm sorry for dragging us too much.
No, it's okay. It's
No,
okay.
no, not at all. It's good
Because
to drag us a bit.
know which one is which.
Yeah, thank you.
You rather drag us now. You rather drag us now than USMLA drag us in that thing.
Than drag. That's true. So hypersensitivity pneumonitis is another one. I have not seen any question on cryptogenic. So, but hypersensitive pneumonitis is very common. They talk about this. We have to know it. So, and it's very easy to recognize. So, it's just like a condition that happens. So it's also from non-cystatic granuloma like sarcoidosis. And the major trigger for hypersensitivity pneumonitis, people that work in the farm, that get exposed to cattle and the likes, the mold within the grass that they eat, and also people that rear pigeon, like some birds, they can get exposed to the antigen from the dung of the bird or from the feathers. So that's what they call the bird fancier disease. I have it here, and the farmers long for exposure to the mold or the Thermophilus bacteria in the farm. So Thermophilus bacteria in the farm and mold in the hay, the grass that those farm animals like the cattle eat. So that's the farmer's lung. Both of them are under hypersensitivity pneumonitis. You see, this hypersensitivity pneumonitis is a long list. We have a lot of things that can trigger it. But before I go to the list, let's just talk about what happens. So, an individual gets exposed to an antigen, which can be from a mold, from Thermophilus bacteria, from bird dropping, or from feather antigen, and that is going to trigger an inflammatory response. This hypersensitivity is usually type 3 and type 4. So that's why it's very common in people with asthma. So there's going to be formation of antigen antibody complex. That's why it's type 3 in the initial phase that is going to be causing the symptoms. Then with time, they start recruiting the T cells and it becomes type 4 chronic disease. But how do you identify this thing? What you need to look out for in the question stem is somebody having asthma-like symptoms. Once you see somebody having fever, wheezing, cough, malaise, that's the acute form. Within about 4 to 6 hours of exposure to maybe a farm or maybe some animal stuff, you get it from the history. You should think of acute hypersensitivity pneumonitis. Now, somebody will now ask me, how do you now differentiate it from asthma? So, in the question, they are going to give you the chest X-ray finding. We are not going to be seeing hyperinflation. So what we are going to be seeing in that kind of person is patchy This is the acute patchy micronodular opacity. That's what you are looking for. So somebody having asthma-like symptoms following exposure to animals in a farm, because of inhalation of the mold or inhalation of the fecal matter, or inhalation of the antigen from the feather or from the bird dropping, and they start developing fever, difficulty in breathing, chest tightness, wheezing. You think about acute hypersensitivity pneumonitis. And what's the trigger? The type 3 hypersensitivity, formation of antigen antibody complex leading to inflammation in the airway. So the antigen is going to be coupling with IgA, and they are going to be forming a complex that's going to be triggering the inflammatory response. When this occurs repeatedly, it will get to a time it's going to become chronic, type 4. Type 4 will now get superimposed on the type 3 hypersensitivity because they start recruiting the T cells into the airway, the lungs. In that condition, they are now going to be having fibrosis. In acute, they don't have fibrosis because the T cells are not involved. So it's only your antigen antibody, which is like your B cells and your antigen. But when it gets repeated like that, continue, T cells will come and they'll start activating the fibroblasts. They'll start depositing collagen, which will cause the lung fibrosis. In them, they will now start presenting with signs and symptoms of the interstitial lung disease, which is what we have said initially. Dyspnea on exertion, non-productive cough, rapid shallow breathing. When you listen to the lungs, there's something I've not talked about, and it's a very, very important examination finding. You hear fine bilateral rales, fine bilateral crackles. Watch out for that in the questions there. Fine bilateral rales, or they can call it velcro-like crackles. Velcro. So velcro means like just like crepitus, stepping on leaves, dry leaves. So velcro, like velcro is fine crackles. So fine bilateral rales or crackles, weight loss. That is chronic hypersensitivity pneumonitis that you are dealing with. So in chronic hypersensitivity pneumonitis, we are not going to be saying micronodular opacity, but instead, it's not even going to be patchy. It's going to be diffuse, interstitial opacity in them. And it's not going to be micro, it's going to be big, and it's going to be diffuse in them. So you just look out for the micro. If it's micro, it's acute. If it's not micro, it's chronic. And in chronic, it is diffuse. And in chronic, they are going to have presentation of pulmonary fibrosis, which is all those things we have talked about. Exertional dyspnea, the non-productive cough, the easy fatigability, the weight loss. And if you do your DLCO in them, if you do your DLCO in the chronic people, it will be low. If you do your DLCO in the acute people, it will be normal. Another clean chart to differentiate them. That's it. It will be normal. But one thing that unifies them is that both of them will cause a restrictive lung pattern. It will cause a restrictive lung pattern on your pulmonary function test. So let's go just a little overview. So a worker that get exposed to the mold, from maybe the grass, from the animal dungs, get exposed to paint, get exposed to agricultural products, get exposed to, so if they get exposed to the mold, that's what we call baggers. So these moldy baggers, I think baggers like A or something. So that's what we call bagasosis. So it's under hypersensitivity pneumonitis. So they will have all these features that we have talked about. And most importantly, you see upper lobe fibrosis, which is widespread and not patchy in chronic. Widespread interstitial fibrosis in the chronic people. And for treatment, for acute, because they develop these symptoms within 4 to 6 hours following exposure, you just tell them to move away from wherever they are making contact with that stuff. You take them out of that exposure, they'll be fine. You don't give them anything. But for chronic, you have to give them steroids to reduce the chronic inflammation. And when it's already like so bad, you want to do lung transplantation. So the most important thing, just remember the pathophysiology, exposure to these animal products, the farmer's lung, and the bird fancier, people that get exposed to the bird, farmers lung, people that get exposed to the A of the cattle, you know, they can develop this condition, and it's mediated by type 3 antigen antibody reaction for the acute, and for the chronic, type 4. In the acute, you don't have fibrosis, so DLCO is normal. In acute, you just see apical micronodular opacity that is patchy. In acute, you just want to withdraw them from the exposure. In chronic, they'll start having features of real interstitial lung disease, proper, you know, and you want to give them steroids and lung transplantation at the end of the day.
Sorry, Dr. Baba. You said in acute, what do you see? You see the micronodular patch in the chronic, right?
The micro
Nodular
nodular
patch.
opacity in the acute.
Micro.
Yes,
Okay.
small.
Okay, micronodular patch. Then in chronic, you see patchy.
So no. You see, the micronodular opacity in acute is patchy. You see
Okay.
it in a patchy
Okay.
distribution. So in chronic, they don't have micro, it's not small, it's big. And it is
Okay.
diffuse.
Okay.
It is diffuse. So, and there'll be extensive area of fibrosis, like that in the lungs, in the chronic one.
Okay.
Yeah, Dr. Bawale, sorry, you said the DLCO is low in chronic and normal in acute, right?
Acute, very correct. That's very correct. So because in the acute, it hasn't got into that fibrosis of the thing. So
Yes.
their DLCO is normal. While chronic, they're already fibrosed. You see, what's it called? Reduced DLCO. So pneumoconiosis. Pneumoconiosis is just talking about inhalation of those organic and non-organic airborne dusts. So we have a lot of them, which you already know. The first one is asbestosis. Asbestosis typically occur in people that work in construction companies. So just think about construction. You are building a house. You have to roof that house. So roofing materials contain asbestos. You need to do the floor. After you have done the roof, you do the floor. Tiles contains asbestos. You have to do wiring. Insulation cables contain asbestos. You need to do waterworks. Plumbing contains asbestos. People that are breaking down all those houses too can get exposed to these asbestos when they are demolishing houses. And the only one that is not connected to all of them is shipbuilding. So asbestos is part of the components we use to make ship. So they can develop asbestosis. And people that develop this condition usually develop it after like 50 to 20 years of exposure. So it's not something that happens acutely. And what are the imaging findings you are expecting that helps you nail the diagnosis quickly? You see interstitial opacities at the base of the lung. That's the number one thing. Then later, the opacity are going to progress into plaques, which can be calcified or not calcified. So the plaques that are calcified, they have the ivory color. I think ivory is like white or something. So they have this white color. So ivory colored pleural plaques are the calcified ones. And where is the location of this plaque? You can see them supradramatic and pleural. So let us see what we are talking about. The supradramatic and the pleural plaques in asbestosis, so that we'll see it on imaging. We'll know. Yes. So look at these images now. So this is diaphragm, right? You can see this white stuff here. So these are the ones in the pleural aspect. These are the ones in diaphragm. This one is not very. This one is like chest X-ray. So let me say CT. Maybe you can see it. CT scan. So most of the time, they might put it in the question stem, so that you just palm your stuff quickly. So these are the pleural plaques here. This white stuff here. So, because of the fact that the diaphragm is just resting on the lungs. So the part of the diaphragm that is that the lungs is resting on, that's the supradiaphragmatic um, diaphragm. So you can have the plaques extending from the pleura to that part of the diaphragm. So it's very typical for asbestosis because everything about asbestosis occurs in the base of the lungs. So that's why it can easily spread to the diaphragm. So you see calcified pleural plaques and supradiaphragmatic. It's not here, but it's part of the features. Supradiaphragmatic pleural plaques, supradiaphragmatic and pleural plaques, on your imaging. And if you do your bronchoalveolar lavage, you can identify ferruginous bodies. Ferruginous body are golden brown, dumbbell-shaped bodies in the alveolar septum of people with asbestosis, and you can identify them by staining that sputum with Prussian blue. So when you stain with Prussian blue, you are going to identify the dumbbell-shaped ferruginous bodies. And what are the complications for asbestosis? The most common complication is what? Lung cancer. We know that it's not mesothelioma, right? It is bronchogenic cancer. So if you see bronchogenic cancer, don't be in haste to go and pick mesothelioma. Mesothelioma is a very, very rare cancer. So asbestosis commonly causes lung cancer, but asbestosis is the only cause for mesothelioma. Asbestosis is the only cause for mesothelioma, but the commonest cancer that comes from asbestosis is lung cancer, bronchogenic carcinoma. So that is that about the complication. The other ones include the co-worker disease. So people that work in all this coal mining, they have this black lung. You see that they are black, their lung is black as if they are smoking. And the major clincher is presence of the small nodular opacity, which is less than 1 cm in the upper lobes of the lungs. Unlike in asbestosis that everything is down, the lower lobes. But in co-worker disease, it is small nodular opacity in the upper lobe of the lungs. And it can lead to progressive, massive fibrosis of the lung, which will lead to restrictive lung disease at the end of the day. So, co-worker disease and silicosis, they are similar in terms of X-ray finding. The only thing that differentiates them is that in silicosis, you are going to see eggshell calcification, which are like well-defined calcification, within the lungs, particularly around the lymph nodes. That's where you are going to see this calcification. So it's classic for silicosis. So both of them have the same imaging finding. And one thing, before I move from this co-worker and silicosis, that both of them, as well as asbestosis, the three of them have the tendency to cause the Kaplan syndrome. So remember, Kaplan syndrome is somebody having pneumoconiosis with rheumatoid arthritis. So what happens is this chronic inflammatory disease is going to lead to dysregulation of the immune cells. They just lose control and they will start attacking the joints. So at the end of the day, you just notice this person develops tender, swollen, metacarpophalangeal joint, sparing the DIP and the other features of rheumatoid arthritis, the early morning stiffness, more than 30 minutes and the likes. So most of the time, they have this condition before the rheumatoid arthritis now setting. So that is Kaplan syndrome. And when you do your imaging, you can see all these things. At the same time, you also see pulmonary nodules, pulmonary nodules in the lungs. That is Kaplan syndrome. It's one of the complications of asbestosis, one of the complications of co-worker disease, complication of silicosis. So silicosis, unlike in co-worker, you don't see it in people that do coal mine. So it's very common in people that mine for, people that do all the sand mining and the likes, working with sand, or people that work in quarries, or people that make glass. So glass contains silica. Pottery too, they use sand, clay. So they can also get silicosis, and people that deal with silica, they can have this same presentation as co-worker, small nodular opacity in the upper zone with the well-defined eggshell calcification. So because of the fact that silicosis have a way of inhibiting the activity of the phago lysosome, so it can be a very high risk for TB. So you have to do another TB testing. Very important for silicosis. They test that concept a lot. So just like co-worker, it can cause progressive massive fibrosis of the lungs. It can lead to Kaplan syndrome, you know, and some other things like pulmonary hypertension because of the hypoxemia and the likes that can develop, cor pulmonale, which we are going to talk about, as we move. So the last one is berylosis. Berylosis, remember hairplay. Asbestosis, shipbuilding. Berylosis, hairplay. High technologies, that's what you are going to see. Electronics, uh, metal plating facilities, high technologies. That's where they use berylosis. So nuclear plant, airspace, um, electronics, dental materials, metal plating, dyes, beryllium. So you might not need to know everything, but once you know for asbestosis, you know for co-worker, you know for silicosis, definitely anything outside that will be the berylosis. So just remember high technologies, metal plating, nuclear plants, aerospace, beryllium. So you are just going to see diffuse infiltrate with hilar, adenopathy, but it's not bilateral in most of the case like sarcoidosis. So you just give your so it for berylosis you can give corticosteroids. So it responds to chronic corticosteroid and you are also going to avoid exposure to the beryllium. Most of the other ones, they don't really steroid don't do much. You just have to minimize exposure and you do supportive care. So which is our pulmonary rehabilitation. So these are the pleural plaques for the asbestosis, pleural plaques everywhere. And this is like the staining histology for the asbestosis. So like this is what is this? Anybody knows this? What is this?
The dumbbell thing.
So this is the ferruginous body. This is the Prussian blue
Yeah.
staining. So so you want to avoid triggers as a treatment. You give oxygen, they are hypoxemic, so that they don't develop cor pulmonale. I forgot to mention, nobody asked me that why do we give long-term oxygen therapy in COPD? Anybody know why we give long-term therapy?
The hypoxic vasoconstriction to reduce it.
Exactly. So you are giving it to relieve the hypoxic vasoconstriction so that the person will not develop right added site failure and cor pulmonale at the end of the day. So that's why you are doing it. So the person is going to have a high chance of survival at the end of the day. So these guys now, supportive therapy, pulmonary rehabilitation, you want to tell them to stop taking whatever stuff they are taking. Maybe they are smokers, stop smoking. They eat very well, good nutritional support, exercise, and of course, oxygen when necessary, supplemental oxygen. So that's how you manage these guys. So
Sorry, can I see the table again, Prof? Just briefly. Okay. All right, that's fine. Thank you.
yeah, you're welcome. So the eosinophilic pulmonary syndromes, the big name is not going to confuse us. Eosinophilic. Eosinophil is high. Pulmonary syndrome, pulmonary condition that has high eosinophil. That's all. So one thing that is peculiar to them is that if you induce the sputum of individuals with any of these conditions, you are going to notice that the eosinophil count is more than 25%. So if you get the sputum from Buccavallar lava, you wash out the lungs, you are going to notice that eosinophil count is more than 25% in them. Of the total white blood cell count there is 25%. If you do your complete blood count, eosinophils is going to be more than 500. So these are the two values that you just need to keep at the back of your mind. That once I have these two values, I know that I'm dealing with an eosinophilic condition. So, and commonly the X-ray will show pulmonary infiltrates. So those are the eosinophils moving around, swimming in the lungs, trying to attack that foreign antigen. That foreign antigen can be anything. The foreign antigen can be aspergillosis. The foreign antigen can be worms, helminths. The foreign antigen can be some drugs. So there are a lot of spectrum for this eosinophilic pulmonary syndrome. So people with ABPA which is the allergic bronchopulmonary aspergillosis that we have talked about. I think we have talked about this. Who remember where we mentioned ABPA? Anybody remembers where we mentioned it?
That's in
Yes.
bronchiectasis or something.
Bronchiectasis. So we mentioned this when we're talking about bronchiectasis.
Bronchiectasis.
Large pressure on mucus that can lead to bronchiectasis. No, don't forget it. Loeffler syndrome, we have talked about this in microbiology. So people with strongyloides or ascariasis, they can have migration from the GI to the lungs. And because they are parasites, eosinophils will follow suit, leading to pulmonary infiltrates on the chest X-ray. If you do your bronchoalveolar lavage, you are going to see high eosinophils more than 25%. Your CBC is going to be more than 500. So with chest pain, with the wheezy, difficulty in breathing, abdominal pain, you can think of, worms like Loeffler syndrome. We know CHOX drugs, eosinophilic and rheumatoid cholangitis, and some drugs too can induce like NSAID, nitrofurantoin, and sulfonamide. So the most important ones here that we are going to focus on, or just only one, is ABPA. That's the major stuff that we really need to know. So Loeffler syndrome is a form of eosinophilic pulmonary disease which is characterized by absent or mild respiratory symptoms like the dry cough, the fleeting migratory pulmonary opacity, and the peripheral blood eosinophilia. So the peripheral blood eosinophilia is a main feature, and you are going to get the other history in the question: the coughing, the wheezing, the rash, abdominal pain, and cramping. So because of this GI involvement, so you might want to suspect the helminth, which is strongyloides stercoralis or ascariasis. So both of them can migrate to the lungs and cause the Loeffler syndrome. So the treatment is just to remove the extrinsic cause of the problem. Say with helminth, you want to give the person, albendazole to take care of it. And if the eosinophil count is very, very high, you might decide to add corticosteroids. So anybody remembers the condition that we are adding corticosteroid when the eosinophil count is high, aside this eosinophilic pulmonary syndrome? Anybody remembers when we talked about it the last class? There's an algorithm. You only had steroids.
Is it asthma?
Is it asthma?
Yes.
No.
No, it's not asthma. There's a particular algorithm that will talk
Is it
about.
not a natural exacerbation of this thing?
No. Who remembers the good algorithm for COPD?
I do remember that's the group E. In group E,
Yes,
when it's greater than 300.
300. Yes, you had steroids. So the good algorithm for stable COPD. So don't forget that. So moving on to allergic bronchopulmonary aspergillosis. So this condition is very common in individuals with asthma and cystic fibrosis. Most of the time, the question stem is going to mention that the person has background asthma, background COPD. Background asthma, background cystic fibrosis. Those two conditions heightens the sensitivity of the airway to aspergillus. Aspergillus is a normal ubiquitous mode that you find in the environment. People inhale it from time to time, but if the person is immunocompetent, the person can easily take care of it without developing any reaction. But people with cystic fibrosis and asthma cannot do that. So when they inhale the spores or the modes, that triggers the type 1 hypersensitivity reaction, releasing your IgE, eosinophils, everything starts coming, leading to recurrent inflammation. When there's inflammation, there is activation of the goblet cells, secrete mucus. The inflammation, the mucus secretion will lead to airway obstruction. So because this thing can occur time to time, superimposed bacterial infection, dilatation of the bronchial airways, leading to bronchiectasis. And eventually, there's going to be fibrosis of the lungs. due to the chronic inflammatory process. So you have to act fast in people with allergic bronchopulmonary aspergillosis because you want to avoid eventual bronchiectasis or pulmonary fibrosis. So how do they present? They can present with typical features of asthma. Typical features of asthma. Sorry, 1 minute. 1 minute. 1 minute, please. So yeah, so I was talking about the presentation. Of course, you are going to get the history of the underlying asthma and the cystic fibrosis, and the person is going to experience the current fever, brownish expectoration. So that brownish expectoration is just blood sticks, which is mixed with the fungal components. And sometimes you can have the inflammatory response so terrible that it gets to the submucosa, leading to hemoptysis. So because the inflammatory process is highly, just chronic, the blood vessels are weak, they can rupture, and the person will have hemoptysis. So sometimes they can just present as exacerbation of asthma, cough, chest pain, wheezing, and maybe, brownish expectoration or hemoptysis, depending on the severity. So, but definitely you are going to get other things in the history or from the investigation that is going to tilt your mind towards allergic bronchopulmonary aspergillosis. So what's the next thing to do? So of course, this presentation I want to raise your suspicion because they might have even given them antibiotics and they will not respond to it. So they want to look for evidence of aspergillus sensitization. What do? You do the skin test. So the skin prick test, you introduce a aspergillus antigen and you wait for skin reaction, the induration. So once you see the induration, after some time, you know that this person actually has antibodies to these aspergillus. That's why the person is reacting. Or you just directly look for aspergillus specific IgE antibodies. Those are the two initial tests that you must do. So either you do the skin prick test or you look for aspergillus specific IgE antibodies. So if you have a negative result for any of these, rules out aspergillosis, you stop your investigation and you look elsewhere. But if you have a positive result from any of these, you progress. And you do that by quantifying the amount of these IgE antibodies to give you an idea of the severity, or you also analyze the level of aspergillus precipitins. So your aspergillus precipitins are just like panels of some immunoglobulins, including IgE, IgM, IgG to aspergillus. Then, of course, the eosinophil count too. You want to know that how much is it, because you expect it to be more than 500 in people with any eosinophilic syndrome. It must be more than 500. So don't forget the first thing: sensitivity, skin prick, or you check for IgE. If it's there, okay, you quantify the IgE, you look for the other ones, IgM, IgE, and you also check your blood count for the eosinophils component. You can do your sputum check, in which you just to further, get this eosinophilic picture. You're going to see eosinophilic rich plugs and Charcot-Leydig crystal. This Charcot-Leydig crystal is present in anything that causes eosinophilia. Even if it's worms, you see it in the stool. If it's aspergillus, you see it in the sputum. So it just indicates that that particular specimen that you are working with has a lot of eosinophils because they are hexagonal bipyramidal crystals which are released from granules found within the cytoplasm of the eosinophils, Charcot-Leydig crystals. So you can do a sputum culture, it's definitely going to grow aspergillus. But you might not need to get to that level. Once you check for your sensitivity, you check your eosinophil count, you look for the aspergillus species. All these ones are faster than growing culture for aspergillus. But this just further, confirms your diagnosis. And once you have that, you can also do imaging. On your imaging, you are just trying to look for evidence of bronchiectasis or pulmonary fibrosis. So I will remember the imaging finding for bronchiectasis. Who wants to remind us? So what's the basic stuff we are looking out for?
Dilated cystic dilatation of the airway at the
Tram
terminal area.
Okay.
That's one
But
that
that's
from
Dr. Antonia,
see,
that's number 3 point. That's number 3
that's
point.
one that have the markings, the tram lines, right?
The trimlines, which is dilatation of the bronchial airway.
Bronchial
Okay.
itself, yeah, and the inflammation itself, right?
Increased
Yes.
increased
Then
pulmonary
it
marking.
has signet ring too, Abi.
Okay. Yes. So yes, Dr. Antonia, increased bronchopulmonary marking.
Bronchosvascular marking, that's true.
Yes, that's on CT.
Mhm.
Sorry, that's on X-ray. On X-ray, you see the increased
Broncho
bronchovascular marking. So on CT, you see the
Dilation.
dilatation of the
Mhm.
airway. You
Airways,
look at
yeah.
it, comparing it with the pulmonary arteries, the pulmonary vessels. You see that that's how you can know that they are dilated. They will be bigger than the neighboring vessels that are surrounding them, and that's what we call the signet ring appearance. Then at the end, you notice that it does not taper. There's absence of that distal tapering because it continue getting wide. And at the end, you see that cystic dilatation that Dr. Antonia was saying. So those are the features of bronchiectasis on CT. So what do you want to do for this patient? Antibiotics will not work. So we have to give steroids and antifungal therapy. And what are the antifungals specific for aspergillus? Itraconazole or voriconazole. Itraconazole or voriconazole, and we add steroid to reduce that massive inflammatory drive that is happening. So because we have said it that it can occur in individuals with cystic fibrosis or asthma, so you want to treat these conditions, you want to optimize their treatment. So people with asthma, because this thing is associated with high level of IgE, you want to give anti-IgE treatment, which is what? Omalizumab, right? So you want to add omalizumab in addition to the antifungal and the steroids to bring down that IgE load, and the omalizumab too can work for people with cystic fibrosis too. So it can also work for them. Then you want to avoid exposure to aspergillus at home. So some of us that will spread our clothes in the house to get dry, can get damp and contain the mold. We have to make sure that we don't have moisture anywhere. We have good ventilation and regular cleaning. So that's how we can reduce aspergillus, mold in the home. So what are the complications for allergic bronchopulmonary aspergillosis? Complications aside bronchiectasis and pulmonary fibrosis can lead to invasive pulmonary aspergillosis and aspergilloma. So these guys can be confusing, but it's good we separate them very well. So invasive aspergillosis just means that you have like progressive lesions in the lungs, and sometimes it can get into the lymph node and the blood vessel and go to other organs. But what are the clinchers for invasive aspergillosis? It doesn't just happen. There have to be like a background of immunosuppression. You will get it in the question stem. Person has background immunosuppression, or neutropenia, maybe from a leukemia, or the person is on drugs, steroids for transplant surgery, and the person will present with this triad: fever, chest pain, hemoptysis. Fever, chest pain, hemoptysis. And when you do your x-ray, you are going to see what we call the halo sign. The halo sign that is specific for invasive pulmonary aspergillosis. And what are we saying with respect to the halo sign? So halo sign just means nodular lesions surrounded by ground glass opacity. So nodular lesions surrounded by ground glass opacity, that is the halo sign. So I forgot to mention that you see reverse halo sign in individual with cryptogenic organizing pneumonia. So instead of nodules being surrounded by ground glass opacity in invasive pulmonary aspergillosis, you now see ground glass opacity being surrounded by nodules. That is your reverse halo sign. It is classic for cryptogenic organizing pneumonia, but you only see it in like 20% of cases. That's why we don't typically talk about it. So, but what is classic for invasive pulmonary aspergillosis is you seeing, I think I should have an image for that. Halo sign. You see nodules surrounded by areas of for invade. Halo sign. Let's even see if we can get. You see, it's already here. Pulmonary nodules are blah blah. We did not talk about what causes it. So we can see differentials. Invasive pulmonary aspergillosis. Invasive. So this is what it looks like. You see the nodules. This white one is a nodules surrounded by the granular opacity. You can see this, hazy opacity. That's granular appearance. It looks hazy. So, and the nodule in between, So this is halo sign, classic for invasive pulmonary aspergillosis. That's what you find in the CT or the X-ray, whatever one that we do. So most commonly we do the CT. Then, don't forget, there's a background immunosuppression, triad of fever, chest pain, hemoptysis, and progressive spread of the nodules within the lungs. It can get to other systems, can go to the brain, meningitis, brain abscess, can go to the joints, osteomyelitis, the eye, endophthalmitis. It can go to the valves, endocarditis, aspergillus. Sometimes you can have aspergilloma. So aspergilloma is an example of a chronic progressive aspergillosis. So we have invasive pulmonary aspergillosis and we have chronic progressive aspergillosis. So an example of a quiescent form or a quiet form of chronic progressive aspergillosis is aspergilloma, which we are very, very familiar with in our step 1. So maybe the person had some infections before that had led to the formation of cavities in the lungs. These cavities can be occupied by the fungal ball aspergilloma, and it will just be there causing nothing. Patient will be asymptomatic. But in some people, they can be symptomatic because that fungal ball can erode into the nearby bronchial vessels, leading to hemoptysis. So you see features of weight loss, hemoptysis, and cough. You do your imaging, you see the cavities with the fungal ball. And if you do your serology for aspergillus, there will be positive IgG serology. So I have skipped some things with invasive. People with invasive, they have positive. The laboratory test that you do is that you assay for the cell wall markers. That's what you check. Yeah, I know I've forgotten to talk about it. So there's something called galactomannan and beta-D-glucan. That's what you are looking out for.
Oh, wow. Dr. Babawale Nwayo. You said you see something in immunoglobulin.
No,
IgE.
that was when I was talking about the aspergilloma.
Sorry,
For the chronic, since IgG is chronic, whatever. So check.
Don't worry, Dr. Anthony, I will arrange it well.
Sorry, Dr. Babale, it's not just her. You got a place I was a bit confused.
Grammar did too much.
I was confused myself.
The grammar did too much. I beg, slow down and repeat it again.
I want to.
No, this you are saying something about this. I think you are saying something on aspergilloma.
Yes. So what I was trying to say is that let's leave aspergilloma for now. I forgot to complete the investigation modality for invasive pulmonary aspergillosis. So, like, there are some biomarkers that we assay for invasive pulmonary aspergillosis, and that's the galactomannan and the beta-D-glucan. So they are cell wall component of the fungi. So they are going to be present in people with invasive pulmonary aspergillosis. Do we get that? Hello?
Yes.
Okay.
Yes.
Now, for aspergilloma, we are not checking for the cell wall component. What we use to make diagnosis of aspergilloma is that we do our chest X-ray, we see the cavity, number 1, and we do our serology. We look for the IgG. for the aspergillus. That's what we are looking for. But one thing that is common to both of them, that if you do it, you see it in both of them, is that if you do your sputum culture, they will both grow aspergillus. If you do your histology and you are looking for the 45-degree branching hyphae, you see it in both of them. So that one is central. But the other specific test is that for aspergilloma, you do your IgG serology. For invasive bronchopulmonary aspergillosis, you assay for your wall markers, beta D-glucan and your galactomana. Do we get that?
Yeah.
Yeah.
So now, how do you treat? You treat them differently. You know that in this guy here, allergic bronchopulmonary aspergillosis, we are giving steroids and antifungal. And the antifungal here is itraconazole and voriconazole. Then, because of the underlying asthma or the cystic fibrosis, we want to give omalizumab, right? But here, what we do for this guy is to use voriconazole. For invasive, you use voriconazole plus or minus capsulfungin. That's what you do. Voriconazole plus or minus capsulfungin. If there's a place you can note it down in our book, we should note it down. So you have to use voriconazole with
Capsulfungin.
Sorry.
Oh, capsulfungin. Okay.
Yeah, a capsulfungin. Yeah.
Okay.
Which is sorry, what am I? Echinocandin, Dr. Antonia. Like,
Yes.
echinocandin is a class. So capsulfungin is
Yes.
an example. So
It does make sense since they have those beta glucans too.
yeah, so you can be combining all those things for to remember exactly. Thank you, Dr. J. So, but for aspergilloma, you use what you typically do for aspergilloma, because you know that what is causing this is the fungal ball occupying the cavity. So what you do is surgical resection. You go there, surgery, you remove it, particularly when it's causing problem. The weight loss, the cough, the hemoptysis. You go there, you remove it. Then you can give them itraconazole. It can work for them too. And if they are having what's it called, bleeding that is terrible, you have to do a bronchial embolization. You have to occlude that bronchial vessel that is bleeding. So most of the time, you give them the antifungal, you go there, you remove that fungal ball in the cavity, and you treat them. So that's the way. So we are just going to quickly look at questions about them so that I can see that we understand what we have talked about.
So for that aspergilloma, you can still give voriconazole or itraconazole.
Yeah, you can give itraconazole. You do a surgical resection, and
And
if
do
there is severe bleeding, you do your bronchial embolization.
Okay.
So a 37-year-old man comes to the office after coughing up a small amount of bright red blood. He has had 3 days of fever, British chest pain, cough productive of thick brown sputum. He has started oral antibiotics for the sputum 2 days ago, but seen no improvement. You can see that statement. See no improvement. The patient received allogenic stem cell transplantation for AML, which was complicated by GVHD, graft-versus-host disease, and prolonged neutropenia. Temperature is 39, blood pressure is 102, pulse is 112, pulmonary examinations revealed right-sided crackus. Lab shows hematocrit of 28, platelet of 140, leukocyte of 15. Chest X-ray reveals a dense right upper lobe infiltrate, which has grown in size when compared to the X-ray from 2 days ago. CT scan of the chest revealed several nodular lesions with surrounding glass opacity in the right upper lobe. The gram stain shows inflammatory cells but no organism. Which of the following is the most likely diagnosis?
Invasive.
Yeah, so it's very, very straightforward. He told us that the upper lobe infiltrate was growing, spreading. and the CT scan shows nodular lesions with surrounding granular opacity.
Hello,
This
sign.
is hello. No, you are correct. I didn't say you are wrong, though.
You said hello sign.
Oh, no, I just said hello sign. Hello sign.
Yeah, okay, hello, sir. Okay. Then we can see the hemoptysis. We can see that the stuff did not respond to the antibiotics. We can see the predisposing factor, which is a immunosuppression from the GV, from the what's it called, from the transplant, and person had
Then Dr. Awale, that temperature self is showing septicemia too, right?
no, this is not sepsis.
It has a very
Yeah, from the infection.
With
From the
that high,
infection. Yeah, fungal infections, they are very chronic infections, so they can cause high fever. Septicemia, well, maybe because the white blood cell count is kind of low. So that's in keeping with that SIRS2. The temperature is high, the BP is not very low. It should be like less than 90, I think, to be in that category. So, Abi, SIRS criteria, temperature greater than 38, less than 36, any one of them. Blood pressure 90, then leukocytosis or leukopenia. Abi, we are forgetting.
yeah, and involvement of other organs. You're
Other
correct.
respiratory rate.
Mm-hmm.
Respiratory rate too. So yeah, it could be, fungal septicemia. So, but that's invasive pulmonary aspergillosis. So let me see if we have any other, question. I think we have some questions lurking around somewhere. I know there's one in the starting. Next time I'm going to be highlighting them with different colors so that I can remember them. So, you know, so a 34-year-old woman comes to the hospital after a day of sudden onset fever, chest tightness, dyspnea, and dry cough. The patient has been hospitalized twice in the past 3 months with similar symptoms, but both times she received antibiotic treatment for pneumonia and the symptoms resolved within 1 to 2 days. She does not use tobacco, alcohol, or drugs. She has no known drug allergies. The temperature is 37.9, the blood pressure is 128, pulse is 92, respiratory rate is 20. So, pulse oximetry is 90 on Roman. The BMI is 29. The patient is in mild respiratory distress. Examination shows normal jugular pressure, no lymphadenopathy, normal heart sounds. Diffused fine crackles ahead throughout both lung fields. Leukocytes are 11,002. CT scan of the chest reveals a bilateral micronodular interstitial pattern. The blood cultures are negative. Which of the following is the most likely diagnosis?
Hypersensitivity pneumonia.
Yeah. Do you want to
chronic
qualify it well?
hypertension.
Huh?
Which one?
Wait, why are we going
Since it's
hypersensitivity?
diabetes,
Oh,
micronodular.
Yeah.
micronodular.
So which one is
So
it?
it's acute to
Yeah.
Yes, exactly.
This is acute hypersensitivity pneumonitis. Micronodular opacity. We can see the
for
asthma-like
Dr. Babali. From
Yes,
the
doctor.
symptomatology, it was looking like chronic, honestly.
No. You can't pick chronic.
Because
You
for
can't pick
acute,
chronic.
I was expecting to see asthma-like symptoms.
I said it that in acute they will have asthma-like. I said in chronic they will have features of interstitial lung disease, which is exertional dyspnea,
Which
dry
is here
cough.
too.
I
Is
think
here
I
too
agree
now.
with that. I even saw the
No.
diffuse fine crackles, with the whole Vacro.
Yeah, they can have
So
that.
it was just
They can have that, but
so I think
see, wait,
CT
relax.
is the defining thing, Nabi.
No. It's not CT. You can still make it out from this history. See, the person had fever, chest tightness. You won't expect this in chronic. This fever, chest tightness, this is tilting towards asthma. Dyspnea, dry cough, chest tightness, and fever. This is asthma, like that. So, it's not that the frank crackles will be there, but The only thing is they will not have fibrosis, and that's why the DSCO, is going to be normal. But they can have the crackles, definitely. So, and of course, they've shown us the CT scan, but you cannot say that this history is supportive of chronic. I will not agree with you. I cannot see chest tightness and I'll think of chronic because I mentioned that asthma is for acute, and part of what we see in asthma is acute chest tightness. So I think the history is is in keeping more with acute than chronic. So there's another one here. A 68-year-old man comes to the office due to progressive dyspnea on exertion and non-productive cough over the past 1 year. The patient now has dyspnea after performing common household chores. He had asthma during childhood but otherwise had no respiratory symptoms until a year ago. He has hypertension and osteoarthritis. Medication includes lisinopril and acetaminophen as needed. The patient has never smoked and drinks alcohol on social occasion. He travels overseas extensively during his long-term career in the Navy and has been retired for 8 years. He has two dogs. Temperature is 37, blood pressure is 143, pulse is 93, respiratory rate 20. Oxygen saturation is 94. BMI is 27, the neck veins are flat. The lung auscultation reveals fine respiratory calculus at the base and the heart sounds are normal without murmur. The abdomen is non-tender without hepatosplenomegaly. No extremity tenderness, no extremity edema is present. Which of the following set of findings are most likely to be observed on pulmonary function of this patient? What do we think?
Dr. Only 1 minute. Thing is so tiny, so
Sorry.
you need to
Exertional,
read it again.
progressive exertional
Okay.
dyspnea and non-productive. Think
Mhm.
of versus cryptogenic,
Keep
progressive,
going.
Mm. Mm.
non-productive.
Go around every.
Think of
Okay.
Let's just go through it, please. Sorry. Antonio, I thought you were reading.
No, I wasn't. I'm looking at the points there. It said progressive exertional dyspnea. So I'm thinking of interstitial lung disease.
Yes.
Interstitial lung disease because it's progressive and progressive dyspnea, exertional dyspnea with dry cough.
Yes.
So it's an interstitial lung disease. So we'll be looking for a restrictive pattern of PFT.
Fantastic.
So restrictive total lung capacity will be
reduce.
reduced. FVC will be normal or increased.
Yes.
And then the efficient capacity will be decreased. Is reduced.
Yeah. So what's the best answer?
A will
A.
be the best
A
answer.
is the
That's
answer.
the correct answer. So that's it. One doesn't even need to know the specific diagnosis. Yeah.
Yeah.
I
But
think
what's the diagnosis? So,
I think this idiopathic pulmonary fibrosis. We did not talk about it. So idiopathic pulmonary fibrosis is likely to be idiopathic.
Makes a lot of sense too, because there's nothing causing this thing.
There's nothing causing it. There's nothing causing it. So that's that. So I think that's okay. So A is the answer. I'm not sure I have any other one. Yeah, I think that's okay. There's one here. There's one here. Are they the same? No, not the same. A 25-year-old. Let me try to expand it if I can. Okay. A 25-year-old previously healthy man comes to the office due to 3 months of progressive dyspnea and non-productive cough. Can we see that consistency in that symptom? Progressive dyspnea, non-productive cough. The patient feels short of breath while cycling 2 miles to the office, which he could do without difficulty in the past. He does not use tobacco or alcohol. The patient works at a publishing firm in New York and has not traveled recently. The family history is significant for asthma in his father. Temperature is 36.7. The BP is 130. The pulse is 78. The respiratory rate is 16. The pulse oximetry is 97. The lungs are clear on auscultation and heart sounds are normal. Lab is as follows: hemoglobin 13, platelet this, leukocyte 8,000, sodium 142, potassium 4.6, creatinine 0.8, calcium 11.4, glucose 98. We need to know the normal values of all these things.
The calcium is high.
Fantastic. So chest X-ray shows mediastinal fullness and scattered reticular opacities in the upper lobes. Which of the following pulmonary function tests is most likely to be observed in this patient?
It will still be the same thing Dr. Antonia just explained now, because they are still the same pattern.
But there's a diagnosis here,
But
right?
the diagnosis here, yeah.
So what's the diagnosis here?
Eosinophilic, eosinophilic, right?
My people.
I'm looking at
eosinophil here. This is a long
hypersensitivity. Hypersensitivity. He works in publishing firm.
Okay, but the publishing firm.
Calcium is high.
But publishing firm is only newspaper. Newspaper is not any
calcium is high. Sarcoidosis.
Yeah. Okay. Look at see. Let me give us a clincher that I feel will help us. You see, when we are done with reading questions like this, we have to start reading questions from the beginning to the end. Once we are done, we can now go to the findings. We look at the findings. That's the next thing. What did they find? Okay. These are the lab results. What is the abnormality in this lab result? The only abnormality we could identify is hypercalcemia. We keep it. We go to our chest X-ray. The chest X-ray showed mediastinal fullness, reticular opacity in the upper lobe.
Oh, okay.
So,
Heliano.
Yeah, this could be because of the fact that the images are tiny, so we might not be able to look at everything easily.
Sorry, can we mute?
So
it's not from me.
So because of the fact that the images is tiny and we might not be able to see everything, so I know that can be the reason why we did not pay attention to the X-ray. But it's important we look at the imaging and the lab value. So mediastinal fullness and the reticular opacity in the upper lungs is classic for sarcoidosis with the hypercalcemia. So that is why sarcoidosis is the answer here. You can see what I'm saying, Dr. Antonia. They will always give you something that you always use to, nail the thing at the end of the day. You can see here now we don't have the erythema nodosum and the blah blah.
Yeah.
So
but the
hypercalcemia is here. I think normal calcium should be 8.4 to 10. So anything more than 10
for 10.2, yeah.
10.2, yeah, I know it's 10.2. 10.2, thank you. So what pattern are we picking now?
It's still the same thing, Dr. It's still restricted. It's still restricted, but the thing is, it's not involving kind of the
So which one are we picking?
So the FEV will be low or decrease.
It will be normal.
Yeah, decrease normal. A will still be answered.
A will be normal.
Will DSA be normal in SAC?
Sarcoidosis reduced.
It should be reduced.
It should be reduced. So which one is
reduced? So which one are we picking?
So to be C?
To be C.
Yes. Yeah, we said
sometimes. Why can't it be C? Why can't it be C?
Yeah, it's C.
That means FEV will be
used or normal. So C will be.
That is why. That's why I did not want to move when you guys were saying that it's the same thing. Because somebody can fall for the trap.
We didn't look.
Sorry.
So FEV can be normal. But the ones that you are sure that will be reduced, you first speed down, you start DSU because it's affecting the lung. So DSU will go down. Total lung capacity will go down. So you can even use that one to confidently pick your answer as C. So that is that. I think that's all I have. So I don't know. I think we are tired because I don't know if I want to move it.
I'm not tired.
We are not tired.
No, but there are a lot of things we need to tie up
I'm
together.
not tired.
We are not tired.
Not
But I'm
at
not
all.
But
really,
I'm hungry.
I'm not really
I'm
prepared for this.
hungry.
Maybe you are hungry.
Dr.
Yes.
Numi is always hungry. We are good.
I have to fill the tank.
I don't know. Maybe we should push it a little.
Yes,
I think
please.
I think all
I'm
these things that are
managing.
here, these things that are here, there are things we already know, so it will not be hard. So
Okay.
moving on to acute respiratory failure. So acute respiratory failure, usually they classify it type 1, type 2. So type 1 is associated with hypoxemia, oxygen level less than 60. So type 2 is usually hypercapnia more than 50. Sorry, but now we are focusing on hypoxemia. So acute respiratory failure just means an acute event that is not allowing adequate gaseous exchange, causing reduction in the oxygen level or elevation of the CO2 level. So here we are looking at the hypoxemic component. Arterial oxygen level less than 60 millimeter of mercury. There are so many things that can cause this. Different levels. Dr. Riley will have talked about it when he was taking us our step 1. So you can look at it from outside to inside. From outside to inside. So from outside, what is the level of oxygen in the outside? Is it that the person is taking in air from a region where oxygen concentration is low, like high altitude? The FiO2, in high altitude is very low. So that is definitely going to affect the oxygen concentration. Is it that the person is not making adequate effort to take in air, hyperventilating, maybe from respiratory paralysis or from depression of the respiratory drive, hyperventilation? Okay, the person is actually taking in air, but is it that the air is finding it very difficult to, okay, I'm going to skip one step if I say that. So it could also be that the amount of air that is sorry guys. It could also be that there's a problem with the lungs, so that oxygen is not able to enter the lungs adequately. The person is actually making effort, but oxygen is not still able to enter adequately into the lungs. So that's ventilation perfusion mismatch. For example, if somebody has pneumonia, the person can try to hyperventilate, but there is fluid in that lung that is not allowing oxygen to settle in. Or the person had surgery, 3 days ago, the lungs collapsed, atelectasis. There's no space. The alveoli that are supposed to allow oxygen to enter, they don't collapse. So there's no place for oxygen to enter. BQ mismatch. Or there's pleural effusion, that's not even allowing the lung to expand very well to take in the oxygen. BQ mismatch. So that's the third level. The fourth level is that oxygen is getting to the airway, but the oxygen is not diffusing out of that airway into the blood. So that is diffusion impairment. And a very good example of that is a patient with pulmonary fibrosis. So if there's pulmonary fibrosis, you will have obliterated that respiratory membrane. So there's no pathway, there's no surface area for oxygen to diffuse from the alveoli into the blood. So that 5 level, any problem with that, any of that 5 level is going to cause hypoxemia. It's very important for us to remember the alveolar gas equation. The way I remember this equation is that I just look at it as PaO2 is talking about the concentration of oxygen in the alveoli, not in the blood, because you are looking at the big A. So this is the big A. It's talking about the concentration of oxygen in the alveoli, right? And I want to, get that concentration of oxygen in the alveoli. So what do I do? And I can, estimate the total amount of oxygen in a way that's coming into the lungs. Okay, I know the total that is coming into the lungs. I want to get the one that is in the lung. Okay, can I know the one that is remaining after the one that is coming into the lungs have entered? I have confused you guys. I know that I've confused you guys by saying what I said, but let me come again. There's a total volume of air coming into the lungs. I want to know the one that eventually gets into the lung and stay there. Okay. Can I use this analogy of mine? It's kind of, I'm the only one that can now understand what I want to say, but it's difficult to pass it across. Let me think of a very easy way to say it. Okay, let's say that there's a total volume entry. There's a part that is going to remain. That part that is remaining is the one that is useful. There's a part of that total that have entered that is useless, that is a waste product. So if I want to know the one that is useful, that is remaining, I'm going to remove the total from the waste product. And the reflection of the waste product is the concentration of CO2 in the blood. The total that is entering the lung ab initio from the atmosphere is this formula, which is the pressure in the atmosphere minus water vapor pressure times the concentration of oxygen in the inspired air. At sea level, the atmospheric pressure is 720. The water vapor pressure is 25. The fraction of inspired air that contains oxygen is 21%. So that means that 760 minus 25 is going to give me maybe 745 times 0.21, which is 21%. You are going to get 154. So they round that down to 150. So the alveolar gas equation is PaO2 equals 150 minus the waste product, which is the concentration of CO2 in the blood. Whatever value it is, over the respiratory quotient of 0.8. I don't know if that can help us remember it in a way. I don't know. But actually, we might not really need to remember that equation. I don't think, but it's just good to know it so that you can understand the pathologies very well. For example, if there's a drop in the FiO2, there's going to be a drop in this. A drop in, atmospheric pressure, there's going to be a drop in this. If there's an increase in this, what do you think will happen to the PaO2? Anybody knows? If there's an increase in PaCO2, what's going to happen to PaO2? Anybody?
It will drop. It will drop.
It should drop.
Drop.
So that is why hypoventilation causes hypoxemia, because if somebody hypoventilates, what do we think happens to the level of PaCO2?
It will increase.
It will
The
increase.
increase, hypo increases.
It will increase. So that means that this value of PaO2 is going to get smaller. So that is why there's hypoxemia when there's hypoventilation. All from this equation. So what is going to be the finding on, depending on the etiology? Most of them will cause reduction in SpO2. That one is constant. So there's going to be ventral cyanosis. So all these ones are not specific. The person wants to hyperventilate, particularly if the cause is not hypoventilation. So the person will be tachypneic. They will experience shortness of breath. Pleuritic chest pain, particularly is from things like maybe pneumonia, pulmonary embolism. They can have pleuritic chest pain. And if there's severe hypercapnia or the hypoxia is very bad, they can have altered mental status. So these are just the history presentation. It doesn't really nail the specific cause. So these are just general findings. So somebody having hypoxemia from any of these things, the first thing to do is your arterial blood gas, of course. That's what is going to review your hypoxemia. From your arterial blood gas, you can obtain your level of PaO2, and that is, sorry, what I mean is P small a, which is the arterial oxygen concentration, not alveolar. So it is from this now that we can now be calculating our PaO2 and the stuff. So, which is the big A. So from your arterial blood gas, you can get your value for your P small AO2. You can get your value for your P small a CO2. You can get your value for your pH, for carbon monoxide level, everything like that. So from there, you can calculate what we call the alveolar arterial gradient. The alveolar arterial gradient. So we already know that this is the equation. The person at sea level, we have this to be 720, we have this to be 25, we have this to be 0.21. We have calculated this already to be 150, but we want to get this. So we just need to get PaCO2 from our arterial blood gas. Then we subtract. After we divide our PCO2 by our respiratory quotient of 0.8, we subtract the value. So any value we get is going to be our big A O2, which is the concentration of oxygen in alveolar. Then we'll have demonstrated our low PaO2 already, which is the hypoxemia proper, the low oxygen. But we want to know the cause. We want to know the cause. So we take out our PCO2 from the 150 and we get our PaO2. Then we calculate the gradient, which is the difference between this big PaO2 and this small PaO2. So normal value should be the age of an individual over 4 plus 4. So normal A gradient should be, let's say an individual is 40 years, should be 40 over 4 plus 4. So if somebody is 40 years, 40 over 4, that's 10 plus 4. So it should be around 14. So it should not be, what's it called? Higher than, the 14. So if it's higher than 14, you know that there's a problem with that individual. So you can either have a normal A gradient or a high A gradient. So I've explained this. So after we have, make your diagnosis of hypoxemia by doing your arterial blood gas, and you have calculated your A gradient, you can now do your chest X-ray to evaluate for the cause of the problem. So for the causes that are downward, which is ventilation perfusion problem, diffusion impairment, right to left shunt, which I did not talk about, I forgot. I'm going to talk about it. We can get that from our chest X-ray. We can get an idea of that from our chest X-ray. So what are we going to find? So if it's an infectious process, pneumonia, of course, we know what we are going to find. Features of consolidation, the homogeneous opacity, depending on type of pneumonia on our chest X-ray. If it's atelectasis, we are going to see that homogeneous, opacity too for atelectasis, but from our respiratory findings, we can actually nail it down to atelectasis, because of the percussion need to be dull, and of course, the tracheal is going to be deviated towards that side. So you can know, okay, the lung have collapsed in that area. So effusion too can be demonstrated on our chest X-ray. ARDS too, we can identify on chest X-ray. So all these are going to cause increased AA gradient. Why? Why increased? Because all these ones that are down, that is, from the airway downwards. What do I mean from the airway downwards? Talking about ventilation perfusion mismatch, right to left shunt, diffusion impairment. They are going to cause only a drop in the small AO2. They will not affect this. So you are going to have a wide value. But somebody that is hypoventilating, or somebody that is what's it called? That is, breathing at high altitude is going to affect both of them. Both the PaO2 and the P small AO2 is going to be decreased. So that difference is going to be normal because both of them will decrease equally. But the summary of the whole stuff is that whenever there's affectation of the lungs, your PaO2 is going to be increased. If the pathology is not from the lung, if it's outside, anything outside the lungs, maybe you are breathing at, high altitude, or the person is just hyperventilating, the AA gradient is going to be normal. So that's the first way to look at it. So, so let us look at the algorithm. You discover your hypoxemia. The next is to calculate your AA gradient. So once you get your value for your AA gradient, you check, is it normal or increased? Is it normal or increased? If it's normal, you know that, okay, this is not likely to be problem with, the airway itself. It can be two things. Is that the person is hyperventilating or the person is breathing at high altitude? So what do you do if it's normal? Two things, hyperventilation or high altitude. So what you cannot do to now differentiate between the two of them is to check your P small a CO2. That is the concentration of CO2 in the blood. We have said it already that someone that is hyperventilating is going to have a high PaCO2. So you know that this is hyperventilation. You now try to check for the cause of the hyperventilation. Why is this person not breathing well? Does he have CNS depression, maybe from stroke or from a drug? Does he have reduced respiratory drives, maybe still from a stroke? Does he have respiratory muscle paralysis, Guillain-Barré, ALS, polio? Does he have obesity, hypoventilation due to fat infiltrating the muscles, the chest wall, mechanism not allowing them move outwards very well and inwards? Could that be the cause of the hypoventilation? You check for that. If the PaCO2 is not increased, then it means that the person is not suffering from hypoventilation. It means that the person is actually breathing at high altitude. So in that kind of person, the FiO2 is going to drop. So look at it now. Let's just look at the scenario. Somebody is breathing at high altitude, FiO2 drops. So you slot in your FiO2 in this equation. At the end of the day, when we slot in low FiO2, what will happen to the big A CO2? Is it going to rise or reduce? Anybody? Hello?
What was your question? Sorry, can you come
Sorry, we
again?
didn't get your question. Sorry.
I said if somebody is breathing at a low FiO2, what is going to happen to the level of the big AO2, that is the alveolar oxygen concentration?
It will be low.
It will be low. What do we think is going to happen to the oxygen concentration in the blood at the end of the day?
Low.
It will be low.
Low.
So if you subtract them, do you think you are going to have an increased gradient or normal gradient? The gradient is going to be
Increased.
normal. No,
Normal.
it's going to be normal. You
Okay,
don't
since
have
both of them
decreased.
are.
You don't have decreased. Is that increased or normal? It's either increased or normal. Do you know why? The reason is that anything that affects big PaO2 is going to affect small PaO2. So you will not have difference at the end of the day. And the only thing that can affect big AO2 is anything from the external. Either you are hyperventilating, causing increase in the PaO2, or the person is breathing at high altitude, causing decrease in this. But someone that has pneumonia or someone that has diffusion impairment, do you think that person is going to have problem with big AO2? No. The oxygen is still there, but it's just that the oxygen cannot find its way into the blood. So it is the blood oxygen that is going to suffer. So in that kind of individual, the alveolar gradient is going to be increased. But if you need a fast way to quickly sort it out and not be thinking, be calculating, anything outside hypoventilation and high altitude, anything outside those two is going to be increased in gradient. But if it's hypoventilation and high altitude, it is going to be a normal AA gradient. So what you are now going to use to separate between high altitude and hypoventilation is to look at your CO2 concentration in the blood, which is this. You expect it to be elevated in hypoventilation, you expect it to be decreased in high altitude. Because in high altitude, you even be hyperventilating and you take out the CO2. If the air gradient is increased, the approach is different. So if it's increased, you know that you are dealing with ventilation perfusion problem, you are dealing with diffusion problem, or you are dealing with a right to left shunt, any of the three. So what do? You give oxygen and you see if oxygen is going to correct it. Now, oxygen is going to correct almost all except shunt. Oxygen does not correct shunt. There are two types of shunt. You have an intracardiac shunt and an intrapulmonary shunt. There is an intracardiac shunt and there is intrapulmonary shunt. Intrapulmonary shunt is also called extreme form of ventilation perfusion mismatch. Let me give us an example of what I'm saying. If somebody has ARDS, in ARDS, for example, I'm going to talk about it. It's very interesting stuff. Almost all the lungs are congested with fluid. So there's no lung that's even open, to allow exchange to happen. Now, what do we think will happen in that situation? If you calculate the VQ ratio, what value are we going to give V? Anybody knows? When almost all the lungs are like gone, what value are we going to give V? We are going to give V 0.
It will be zero, more of obstruction.
Yes, and Q will still be there. So in that is, you can't divide 0 by something. That's infinity. So that's short. But maybe you just have, like, let's say somebody has maybe pneumonia just occurring within small part of the lobe. The lower lobe, the middle lobe, they are still active. Small hair can still get there. So they will just have reduced ventilation to perfusion. So we call that ventilation perfusion mismatch. Do you understand that? There's a reduced VQ ratio. Do we get what I'm saying? Hello?
Yes.
Yes.
So depending on the severity, if somebody has pneumonia that's affecting almost all the lungs, congesting almost the entire lung, ventilation will be 0. Because of the massive consolidation, leading to a shunt, because the blood will just be passing through. They will not be ventilated. That is what you call intrapulmonary shunt. But intracardiac shunt occurs when you have blood moving from the right side to the left side. When blood moves from the right side to the left side, it means that deoxygenated blood is going to be mixing with oxygenated blood, deoxygenating that deoxygenated blood, reducing the oxygen concentration. So it's like you are shunting it across the pulmonary arteries and it's not getting oxygen. Because the word shunt means that the blood is just moving from the vein is moving from the artery rather to the vein without getting any oxygen. And that is what is going to happen if somebody has maybe a TOF, or somebody has tricuspid atresia that's not allowing, that is causing deoxygenated blood to mix with oxygenated blood. So it gives the same impression as if blood is just passing from the pulmonary artery, bypassing, shunting across the pulmonary capillaries directly into the pulmonary vein. It means the oxygenated blood in the pulmonary artery is just going into the pulmonary vein without getting oxygenated. That is a shunt. And that can happen in a condition where the lungs are congested so much, or they are damaged so much that oxygen cannot get in there to enter into the lungs. The person will still be having deoxygenated blood. If you give that person 1 billion oxygen, there's nothing that can change, because there's no space to even take the oxygen. The lungs are collapsed. When somebody has massive atelectasis and you are not giving oxygen, is the oxygen you are giving going to open that lungs that have collapsed? No. So ventilation is still going to be 0, and the person is still going to be receiving blood. The blood will be moving from the pulmonary artery to the capillary to the vein without getting oxygenated. So it's like it's shunting across the capillary without getting oxygenated because of that 0 ventilation. That is intrapulmonary shunting. Intracardiac means a right to left mix of blood. When you give them oxygen, nothing is going to change. Nothing is going to change. But in VQ mismatch, due to low ventilation to perfusion or reduced perfusion to ventilation, if you give oxygen, it can improve the condition because you still have other airway that are open, to take the oxygen and use it for their benefit. So, somebody that has asthma now, that is not very bad, just mild asthma, COPD, that the ventilation is not 0, air is still passing through gradually. They will just have reduced ventilation perfusion. If you give oxygen, it will help. Interstitial lung disease, if you give oxygen to them, it's not all the lung that is fibrotic. So the oxygen will diffuse to the other parts, of the lung that are still okay, and they will, improve the oxygen concentration. Atelectasis that is not severe, pneumonia that is mild, pulmonary edema that is mild, the same thing. Increase in pulmonary vascular resistance or pulmonary vascular disease rather. Someone that has PE. In PE that is not massive, it's just occlusion of few or 1 or 2 vessels that is occluded. There will be constriction of those vessels and blood will be shunted to the other vessels that are open so that your oxygen can diffuse and they will receive it. Easy. So just see intrapulmonary shunt as a severe form of VQ mismatch. That is it. That is it. That is it. And it's not correctable with oxygen because you don't have any lung that is functioning to take care of the oxygen you are supplying. So if the problem is hypoventilation or low inspired oxygen, you can see that they have already given us that fact here. The air gradient to be normal. But if the problem is VQ mismatch or shunting or diffusion abnormality, the air gradient is going to be increased because in them, it's only going to affect the oxygen concentration. But in hypoventilation and low inspired oxygen, is going to affect both alveolar oxygen concentration and arterial oxygen concentration. So the gradient will be normal at the end of the day. So,
Dr. Abawale, please, before you go further, I have a question.
yes,
You know, explaining, can you hear me?
Yes, I can.
Okay. So you were explaining to us about the intrapulmonary shunts, and one of the examples you gave was that of alveolar, what's it called now? Atelectasis,
Yes.
that once we
Massive.
have
Massive.
long active, okay.
Massive.
Okay.
That's the word.
So yeah, so in case, so what do you think for our exam? Is it possible that, like, which scenario are we likely going to have that atelectasis? Is it going to be under the shunt, the intrapulmonary shunt, or is it going to come under the what's it called, under the VQ mismatch?
So the way I feel, though I don't think I've seen any question, but the way I feel is going to come is that, number one, because before you do anything, after you have discovered hypoxemia, you will give oxygen. That's the first thing. You don't even know the cause. You give oxygen first, bam, because you can see that there's low oxygen. Now come oxygen, bam, take. If you notice that the person is not improving with oxygen, you definitely know that this is what you are dealing with. Shunt. You now look at the question stem. What is the option? I can assure you, Dr. Dorothy, the question stem is going to mention shunt as part of the option.
Okay.
They will put it there because you have identified you have identified a clue to give you the likely pathology. No improvement with oxygen. So definitely you know that the problem is a very severe problem. Massive atelectasis, acute respiratory distress syndrome. People with acute respiratory distress syndrome is not play. most of the time they will end up on mechanical ventilation because it affects like both lungs. That's why if anybody remembers the Berlin criteria for ARDS, there's something about the chest X-ray. Anybody remember from our step 1 for ARDS? Anybody?
Sorry, Dr. Baba, what did you say? Sorry.
If it is it the
What was your question? Sorry, Dr. Baba.
Is it that
coordination?
you guys are not because
No, I heard the ARDS,
You
but I
know,
didn't hear what you mentioned.
that X-ray finding.
yes,
So the
yes,
bilateral lung
yes,
opacity.
you can see
Yeah.
bilateral, both lungs are affected. What do we think will happen to that BQ mismatch in that person?
It will be
There's not going to be any. It's going
It
to be
should-
thinner.
They usually have
Is it going to be reduced BQ mismatch or shunt? Which one is it going
It's
to be?
reduced.
It is shunt because
It's
that
shunt.
V,
Because it's bilateral.
yeah, because that V is going to be 0. It's going to be shunt. So don't forget, shunt is extreme VQ mismatch for intrapulmonary, extreme reduction in the VQ mismatch, so that the V is almost 0. I think they stated that fact very well in our step 1 FA. They did not put it very well here. And the other form of the shunt is intracardiac, which you all know very well. So you administer oxygen before you even start evaluating. You check the response to that oxygen so that it will guide you on what you do. So then increase oxygenation parameter on mechanical. We are going to talk about mechanical ventilation. Don't worry, very straightforward. So there are some things that you need to adjust to increase oxygenation on your mechanical ventilation. That is your FiO2 and your PEEP. You need to increase both of them, but you don't over increase, because if you over increase PEEP, that's barotrauma. If you over increase FiO2, that is oxygen toxicity. We are going to talk about it, when we get there. Oh, it's even here. The stuff is here. So I don't know it here. So 2 things to do to increase oxygen on mechanical ventilation. So let's say that at the end of the day, this person had ARDS, shunt, and you have to give this person mechanical ventilation support while you treat the underlying cause of the ARDS. Because if you do not treat that ARDS, the oxygen will not do anything. So if you want to increase oxygenation, so for any other cause, many other disease, you have to increase your FiO2, which is the fractional oxygen concentration in the air you are taking in, or the positive end expiratory pressure. What this is going to do is to keep the alveoli open. It recruits more alveoli. Even the ones that have closed, it will go and open them. Do we remember when we were talking about COPD? When we were talking about this positive end expiratory pressure you are delivering to keep the stuff open at expiration. Anybody remembers? The PEEP.
Yes.
Yeah.
This is exactly what we are saying. So somebody has atelectasis. You place the person on mechanical ventilator. If you deliver your PEEP, what you are doing is that you can open up those alveoli that have closed, recruit them so that they can, provide an avenue for oxygen exchange. That's what you are doing. You also give it in people with ARDS, because in ARDS, there's fluid washout in ARDS. That fluid that's entering that lung is washing out surfactants. And we know the role of surfactant. What does surfactant do? Anybody?
It prevents the lungs from
Reduce surface tension.
the alveoli.
Reduce the
Yes.
surface.
Thank you. It reduces surface tension. Dr. Antonia, how
boss.
can you explain surface tension to me? Like your understanding. Like what does it mean?
It's okay. No.
Like a pressure,
Okay.
a pressure in the surface that can lead to make it to be easily collapsible. I don't know how.
Yes, I agree with you. So look at it as a pressure that is trying to bring the airway together, collapse them, bam, bring them together. That is surface tension. So now in what's it called? In this
What you said
ARDS.
was that the fluid, it prevents fluid washout. You were talking about the fluid washout.
Yeah, no, in ARDS, there's fluid washing out the surfactants. So there's going to be increased surface tension, and the alveoli are going to collapse on themselves. So that's why you have to administer PEEP so that you can open them and recruit them for oxygenation. Dr. Oloroti, I don't know if that's
Yes, yes.
so.
Thank
That
you.
is the way it works. Or you can increase ventilation. So somebody that is already tired. The person cannot even hyperventilate again. They get shallow breath. So you want to take over that ventilation. So you need to place that person on the mechanical ventilation. So this is not a time to be giving that person CPAP or BiPAP. We remember that I said that BiPAP, it is a patient that is controlling the ventilation. You are only giving PEEP so that you can promote oxygenation. But if the patient cannot ventilate, you have to place on mechanical ventilator so that the person, it is a machine that will be triggering the breath, and the person will be having ventilatory support. If you want to increase that ventilation or decrease that ventilation in your mechanical ventilator, what you are going to do is to adjust any one of your respiratory rate or your tidal volume. I have explained it in one equation. I said minute ventilation or minute ventilation equals the respiratory rate times the tidal volume. Anybody remembers when I said it? Respiratory rate times tidal volume. If you increase
Yes.
respiratory rate, you increase ventilation. If you increase tidal volume, you increase ventilation. So, in hypercapnic patients, I said acute respiratory failure can be hypercapnic or hypoxemic. So anybody that is hypoxemic, this is what you want to do. Increase FiO2, increase PEEP. But if the person is hypercapnic, the only way to take care of hypercapnia is to hyperventilate. So you want to increase ventilation parameters in them by increasing their respiratory rate or increasing tidal volume. That's what you do. You increase the respiratory rate or you increase tidal volume. But one thing about increasing tidal volume is that if you increase tidal volume, so they usually prefer to increase respiratory rate than to increase tidal volume, because if you increase the tidal volume too much, it will get to a point that the respiratory rate will want to compensate for that increase in tidal volume, and it will go down. And when the respiratory rate goes down, there's going to be hypercapnia, and you will worsen what you are even trying to correct. So if we are to choose between one, we always go for increasing respiratory rate. Even if you increase tidal volume too, tidal volume increase can also cause volutrauma. So you have to be very careful with increasing tidal volume. And I'm going to explain it as we move further. So let's just quickly look at acute respiratory syndrome and see if we can talk about mechanical ventilation. Then let's see. So acute respiratory distress syndrome, it's a diagnosis of exclusion too. So it's just respiratory failure with refractory. You can see the word refractory hypoxemia. It means that your ventilation is zero. It's very difficult to correct until you treat the underlying cause. And we need to understand the pathophysiology of what is happening before we can understand all this statement that is here. The first thing is that the common cause of acute respiratory distress syndrome is sepsis. Sepsis is the commonest cause. We have other things that can cause it, like someone that has a severe pulmonary infection, pneumonias, someone that had experienced aspiration of anything, gastric acid aspiration, due to lack of control over the airway, massive blood transfusion, people that have inhaled or ingested some toxins, or people that have drowned. So most commonly in our USMLE, you see them talking about drowning, you see them talking about sepsis, you see them talking about, I think that's the two common one, and trauma as a cause. So what happens? In all of these conditions, you typically have activation of the inflammatory cells. So acute pancreatitis is another one that they missed out. They like putting ARDS with acute pancreatitis. Is a common complication of acute pancreatitis because acute pancreatitis is a condition that's actually with like release of massive amount of cytokines. So those inflammatory mediators being released from the sepsis, from the pneumonia, from the trauma, everything like that, they will recruit the neutrophils to the lungs. And when they get to the lungs, they will release their, they will form the reactive oxygen species, those cytokines, interleukin 1 and 2. They will affect the integrity of the endothelial cells, leading to extravasation of fluid into the alveoli. We remember that this is the way the alveoli is. There is the alveoli like this. You have a respiratory membrane and you have the capillary beneath. Now, people that have sepsis, people that have pneumonia, a lot of cytokines playing here. So they are going to invite the neutrophils. The neutrophils come to this place in the blood. They will release their proteins. They will release reactive oxygen species that is going to damage this endothelial membrane of their wall. And fluid is going to leave like this, leave here, move across this respiratory membrane into the alveoli. So you see a lot of congestion here. That is a simplex explanation of what is happening in ARDS. Now, you are going to have pulmonary edema because of this. And this pulmonary edema is not going to come from cardiac origin. So that is part of what we are going to rule out. We are going to rule out fluid overload. We are going to rule out heart failure. Is it that this person get heart failure? Oh, we don't do our echo. This person doesn't have heart failure now. Diagnosis of exclusion. Did the person take 50 bag of 500 mils normal saline? No, we did not overload this patient. This is coming from an inflammatory event, maybe from acute pancreatitis, from trauma, from sepsis, from pneumonia, leading to non-cardiogenic pulmonary edema. So how are we going to know that this is a non-cardiogenic pulmonary edema? Which anybody remembers how we are going to know? What parameter are we going to look out for? Anybody?
Transportation.
BNP, Abby.
No,
No time. You will not do BNP. No, it's not BNP.
I say PCWP, Dr.
Nice.
Bobowa.
So you do
Okay,
your
yeah.
PCWP. So your PCWP is not going to be elevated. Your PCWP gives you reflection of your left atrial pressure. This is not coming from heart failure. So the left heart did not fail. So your PCWP will be normal in the face of pulmonary edema. You already know what you are dealing with is likely to be acute respiratory distress syndrome. The mortality rate is 30 to 40%, very, very high. So we need to be fast in what we are doing. So one thing I need to also say before I leave here is that the onset is usually within 24 hours. That's the average, is 24. If you have this kind of presentation, you have that maybe fluid in the stuff and something that looks like acute respiratory distress syndrome, before 24 hours, you think of pulmonary contusion. Classic stuff, pulmonary contusion. If the symptoms did not start after 24 hours, don't pick acute respiratory distress syndrome in the option, please. So, how is the patient going to present? Tachypnea, the patient will try to hyperventilate to get in more oxygen, which is not going to work. Of course, the patient is being respiratory distress. There's tachycardia because of activation of the sympathetic nervous system, because of the hypoxemia. Depending on the cause, there might be fever or there might not be fever. The person will be cyanosed depending on severity, and of course, in most of the cases, it will eventually lead to cyanosis. You listen to the chest, you are going to hear rales, crackles due to fluid, in the lungs. So hypoxemia is going to happen due to the systemic inflammatory, cause or exposure. So before I leave this diagram, I need to talk about what happens when fluid extravasate into this alveoli. They are going to congest that lung. There's going to be an increase in the work of breathing. You start using accessory muscles and the likes. At the same time, because part of the fluid that is entering, there's a very high protein content in that fluid. They're going to form what we call hyaline membrane. You see, that hyaline membrane is what is now causing problem, because that hyaline membrane is a proteinaceous membrane in the alveoli that is preventing oxygen from moving, that is moving up from the atmosphere to pass into the blood. That hyaline membrane is part of what is causing the problem. So hyaline membrane is part of the typical thing that is formed in someone that has ARDS. With the congestion, which is causing the hypoxemia, increasing the work of breathing. There's something I remember that I've forgotten. I wanted to say something, but it came to my mind, but it has disappeared again. Maybe I'll remember as we move downwards. Yes, and we also remember that because of this fluid that is here, it's going to wash out the surfactants that is in the alveoli. And when the surfactants are gone, that means there's nothing to reduce surface tension. That means elastic recoil is going to increase. The lungs are going to now move towards each other, like something like this. Like this is surface tension. Force acting like this, coming together. Bam! That's surface tension. So your surfactant is preventing this. But once there's no surfactant to stop this, this one will come like this one will come like this, and they will collapse the airway. Bam! And at the end of the day, the person is going to have hypoxemia. So these are the typical response. Because of the acute state, they can have respiratory alkalosis. They start hyperventilating, leading to respiratory alkalosis. The hyperventilation becomes so great that it will eventually lead to hypocapnia. And of course, this is a problem affecting the lungs, so we expect the A gradient to be widened. At the end of the day, the oxygen level is going to be so low, less than 60. Person with acute dyspneic, reduce the lung compliance, particularly when the surfactants has been washed out. Because lung compliance is when this one is moving this way and this one is moving that way, and they can stretch. But when the direction is now like this one going like this one going like this, collapsing on themselves, that is reduced compliance. So you listen to the chest, you hear the rales. So I don't think we need to learn the faces. Nobody's going to ask us what is the face of this acute respiratory distress. Nobody's going to ask us that. So at the end of the day, it's going to cause severe hypoxemia, which is not going to be responsive to oxygen because of the increase in intrapulmonary shunting with eventual metabolic and respiratory acidosis. Because when it gets to a time, the muscles will be fatigued. The breathing rate is going to drop. So the person is going to have respiratory acidosis. And because of the drop in the level of oxygen, the person is going to follow the anaerobic pathway of metabolism, leading to formation of lactate. So our glucose pyruvate product, they are not entering oxidative phosphorylation pathway again. So they are just doing glycolysis. So lactic acidosis is going to be, accumulating, leading to metabolic acidosis. So there's something we call the Berlin criteria, which are a set of criteria that we need to look out for to make diagnosis of ARDS after we have excluded all the other possibilities. And the first thing is having this respiratory failure, the hypoxemia, within 1 week of insult. So within 1 week of pulmonary infection, within 1 week of sepsis, within 1 week of the trauma, the person develops hypoxemia, respiratory failure. That's number one criteria. Number two criteria, and the typical time is after 24 hours, right? But within 1 week. The next thing is the fluid congestion, both sides of the lung. So you are going to see bilateral opacity, bilateral opacity, bilateral opacity. The third symptom, the top finding is going to be a PaO2 over FiO2 concentration less than or equal to 300. So what we are saying, at usually at the peak of 5, when the PEEP is 5 and the we are still delivering some airway pressure, we check our PaO2 over FiO2, it's less than 300. This is classic for ARDS. The starting problem for the starting level of ARDS. Sometimes it gets so low that it gets to like 150. When it gets to 150, that's when we start doing the prone positioning and the likes. So the reason is because we know that ARDS is going to cause hypoxemia. So definitely our PaO2 is going to drop. So the PaO2 over FiO2, when we measure it, we will notice that it's less than 300. Ideally, it should be more than 300 in someone that is healthy. But people with ARDS, because of the drop in the PaO2, is going to be less or equal to 300. That's the third criteria. Then the fourth criteria is when we have ruled out the other causes. It's a diagnosis of exclusion. So we have ruled out massive fluid transfusion or fluid administration and heart failure. They are not the cause of the pulmonary edema. Can definitely say that, okay, what we are dealing with is ARDS. So Berlin classification, acute onset, less than 1 week of respiratory distress, chest X-ray showing the bilateral alveolar opacities consistent with pulmonary edema. Pulmonary edema on chest X-ray before 24 hours after trauma may suggest pulmonary contusion instead of ARDS. So pulmonary contusion it's just like leakage of blood from, like a form of destruction of the pulmonary capillaries versus they are leaking blood into the lung parenchyma. That's like contusion. And most of the case, it follows trauma. So it can give, similar opacity like in someone that has ARDS. But the symptoms and the opacity develop usually within 24 hours of the injury. So, and you see broken ribs and all. This X-ray is not clear. I'm sorry. We cannot use this X-ray we cannot make out much from this X-ray because ideally we are supposed to be seeing the broken ribs and the opacity, but we just know that this one is just a little bit opaque compared to this. So, and maybe there's a form of pneumothorax, here. And I think this trachea is deviating. Anybody? Can we say that this trachea is deviating like this?
Yeah.
So it's kind of deviating, towards the side in a way. So yeah, it's even stated here pneumothorax reflex, but it's not a very clear image. So FiO2, PaO2 FiO2 ratio less than 300 with a PEEP of 5. Why you are still delivering this PEEP? You are having this value. Classic for ARDS, and the respiratory failure not explained by heart failure or fluid overload. So yeah, so how do we treat? So how do we treat ARDS? You have to treat the underlying cause. So sepsis, you give fluid, you give antibiotics, drops, depending on the degree. You maintain adequate perfusion to prevent end organ damage. Very, very important. Prone positioning. So there's something we call prone positioning. So that prone positioning is just to ensure that you are equilibrating ventilation perfusion across all lung zones. So let us the first fact is that majority of the alveoli are located in the dorsal or the distal aspect of the lungs. That's where they are. They are in the distal aspect. Now, if somebody is lying supine, we hospitalize the patient. We know that most of the patients that we admit, they are lying supine, and we don't place our patient probe. So, if a patient is lying supine, it means that the heart is going to be compressing on the lung tissue that is, that is down. That is what gravity is going to be acting on. I don't know if you can picture what I'm saying. Please just imagine that somebody is lying supine. it means that the weight of the heart will be directly on the one that is ventral, like the alveoli is ventral, but the one that is going to be getting compressed more is the one that is at the down, which is the dorsal alveoli. Do we get what I'm saying?
Yeah. Yes.
But I'm not getting response. So let me just say that this is the heart. This is the lung tube. There's some alveoli here, pam, pam, pam. There are some that are more dorsal. If somebody is acting supine, gravity is going to be acting like this. So the alveoli that is getting more compressed are the ones that are here. Do you understand that? They are the ones
Yes.
that are here.
The
And
one,
this is
the one,
eh?
the ones that are anterior are the ones being
No.
compressed.
The one that are dorsal, those are the ones that's
Okay.
going to be, because gravity is going to be acting like this. So now the one with the ground here could suffer pass.
Okay.
So
Dr. Babawale,
yes, Dr. Oluwati.
yes. I don't know, maybe you want us to ask a question after class. I mean, after you finish this, but before you go further, I want to ask you something. When you were explaining the diagnosis to us, you spoke about the Berlin diagnosis. You talked about the acute onset. That um, you said something that it have to be that some once you start having the symptoms after like 24 hours or something, right?
Yes, before 24 hours. I was talking about
Because
pulmonary contusion there. The imaging.
no, I know the contusion. No, that one for the pulmonary contusion should be that one have to do with pulmonary edema on X-ray, on chest X-ray.
Yes.
Yes, that's not the one I'm talking about.
Okay.
You first talked about, the symptoms that the patient is going to present with without X-ray. That's the
Okay.
one I'm saying for.
Okay.
Yeah.
Okay.
Can you put more clarity on that? Do I have another question after that?
With the symptom. Okay, maybe I made a mistake when I was talking. So I meant imaging, not
Oh,
symptoms. Like we seen that imaging, that opacity developing within 24 hours. I think that's what
okay.
I meant. That
Okay.
if it appears before 24 hours, it's likely to be pulmonary contusion.
Yes.
You will see the imaging after 24 hours, usually for ARDS.
Okay.
I think I made a mistake when I was saying that. I think that's where you.
Okay. Okay. So there is no symptoms. It's not safe for
No.
accurate. Okay.
No, they can have symptoms. They will have symptoms. Okay, you meant clinical symptoms.
Talking about the clinical symptoms, I understand that of the X-ray.
What you mentioned was
Yes.
you said there will be symptoms, but the symptoms of respiratory failures will not be due to
Happen initially. Yes. So
what you
like
mentioned.
they can. That's why it's graded. That's why it's graded like this. See, uh, like initially they might have normal respiratory finding, but later they will now start having hyperventilation within like 6 hours. Dr. Roth, is that what you are trying to clarify?
Yeah, I just want you to, everything. After a while, you said something else, so I just got a bit confused.
Okay, please,
So
can you come again? Let me know.
can you just maybe just wrap it up again in just few words? What you find with the clinical symptoms? Though I understand the chest X-ray.
Okay, I think what I was trying to say initially that got you confused was this pulmonary edema feature on X-ray. So
Okay.
the point I want to make there is that you don't typically see this pulmonary edema feature within 24 hours. It's usually after 24 hours for ARDS.
Yes.
If you see something that looks like it within 24 hours of trauma, is going to be for pulmonary contusion.
Yes. But that would be on X-ray.
That will be on X-ray.
Okay.
That's the point I was trying to make.
Okay.
So I think I made a mistake. I was talking about symptoms, symptomatology. I think that was that what I said?
Yeah, you've explained before when you were at the beginning. Then when you got to diagnosis again, you now said something. So I was just confused. That is it, the symptoms again, or what are
No.
exactly are you?
I think that was what I was trying to say. But part of the criteria is this number one: acute onset of the symptoms within 1 week of respiratory distress. Within 1 week of the respiratory insult. This statement is kind of confusing. It's like
Yeah.
within 1 week of the insult. That's what it should be.
Okay.
Within 1 week of the insult, they would have the symptoms. If we
Okay.
check let me see what we have in our old one. I have the step one here.
Okay.
Let me see what we have there. So you can see rapid failure within 1 week of alveolar insult. That one makes sense more than what is there.
Okay.
Dr. Rod, can you see?
Yes, I can.
Within 1 week of alveolar insult, respiratory failure. But here, they are
Can the
saying,
font size of this thing be increased? Okay. Thank you. It's okay.
so
Thank you.
the haze is the abnormal chest X-ray, which you usually see like after 24 hours. That's when it start manifesting. After 24 hours.
Mm-hmm.
Because
Yeah.
it involves inflammatory damage to the movement of fluid and all those things.
That's right.
The respiratory failure too will develop within 1 week of the insult, which is maybe the trauma, the sepsis, the whatever cause.
Okay.
And this that we have talked about. So here now they said, there are some tiny mistakes that are actually in this book that we need to be careful of. There are some I will show some mistakes that I discovered. So here they said acute onset of respiratory distress. Okay, well, I think I get them to acute onset of respiratory distress. Yeah, so like the respiratory distress develop within 1 week. That's what they are also trying to say. But it should be more clear that within 1 week of the insult.
Mhm.
Do you get, Dr. Roti?
Yes,
So
yes.
where
You
I made
do.
a mistake was when I was talking about the X-ray. It should be
But that's clear. But that X-ray is clear to me.
yes. So I think everything is solved now.
Okay.
So
So then
But
the
but
other thing I
but
want to
this,
talk about is the that PaO2 FiO2 ratio.
okay,
Yes.
this okay.
Yes, this one.
Yes, PiO2 is a function of the amount of air you are taking in. Like the air you are taking in the atmosphere, what's the content of oxygen? You know that we don't have control over that. Dr. Roti, you don't have
Yes,
control over
I'm
your
hearing
own.
you.
I
Yes.
don't have control over my own. But I can
Yes.
control it with a machine, with mechanical
Mm,
ventilation. But this person is not on mechanical ventilation. But now, let's say the person is not on mechanical ventilation.
yeah.
So FiO2 might be normal. So, but this one definitely will be reduced because of all these problems. So if this one is reduced, if you calculate the ratio will be less than 300.
Okay.
Do you get it, Dr. Roti?
Yes, I do. So, the formula you gave us earlier, that's capital letter A, the PaO2 equals to the atmospheric pressure,
Yes.
my the that of is it that of um partial pressure of water, times the FiO2. I don't know, where do we have the the small O2 there?
Yeah, so PA small O2 is gotten from the ABG.
Oh,
That is
okay.
it. That is the first thing that we are going to I've messed up this. That is the first thing that we are going to get, Dr.
Okay,
Roti.
because I was trying to relate it to
You
the
mentioned it earlier too, Dr. Morali.
Yes, like Dr. Roti, see, patient comes to the emergency bara. Boom. We just do
Sorry, Dr.
ABG.
Babali. Sorry, can I say something? I hope we all still remember that we can rewatch the videos on the website so that he doesn't keep saying the same things over and over because one person missed a part of it. Because I've also missed some things, but I'm not. And I know that he said those things, so I wouldn't keep taking him back. So if we miss some things, rather instead of it's a different thing if we didn't understand But if we missed some things, we can just be patient and just mark it and then go back to the website. That's why there are recordings on the website, so that he doesn't keep repeating himself and then he keeps thinking he made a mistake meanwhile he actually said those things.
Okay.
Well, I didn't hear this one. So
It's fine. Dr. Rotti,
yeah.
see, this is just a summary. This is just a summary so that we can move on. When a patient comes in, the first thing you do, advanced country like this, they do the ABG. So from the ABG, you can get the value for the oxygen concentration, the CO2 concentration in the blood. So once you check the oxygen concentration in the blood, it is low. We know that this is hypoxemia, right? We have made that diagnosis already. This is hypoxemia. So the next thing, we want to administer oxygen. Does it improve with oxygen or not? That can tell us if it's shunt or something else. But before we even get to that level, you can calculate the AA gradient too, so that you can classify it into what type of hypoxemia we are dealing with. And how do we calculate the AA gradient? We already know the small a, which is the one we got from our ABG. And we know the parameters we need for the big A. We know the parameters that we need. We just need 150 minus this. And this is also part of what we can get from the ABG, the PaCO2. So once we put in our value of PaCO2 here, we slot in the stuff here and we minus it from that of the Pa small AO2, we'll get the AA gradient. See, Dr. Rotti, this one here is the big AO2. 150 minus PaCO2 over 0.8 is the big AO2. It is this formula that I wrote here. This is it. You see this value here, this thing here is 150. We have calculated it to be 150.
Yes.
So once you remove it from the value of PaO2 that you get from the PaCO2 that you get from your ABG, you get your value of PaO2 straight off, the big one. Once you have this one, you just remove it from the small AO2 and you get your A gradient.
Okay.
So the value of that will now tell you of what you are dealing with. Is it normal? Is it increased? If it's normal, you know that this is the pathway you are following. If it's increased, you know that it's one of these guys. So to separate between these guys, the oxygen you will have given initially will have told you what has happened. So if you have given the oxygen initially and it's not correct, you know that's a shunt. So then if it's corrected, then you can now use your chest X-ray to now look at any one of these guys. So Dr. Rotti, is it clear, little?
Yeah. Thank you.
Okay. So okay, yeah. So the prone, I was trying to explain the prone. So I said, just imagine the patient is lying supine. If you're lying supine, the heart is just up, the lungs are down. So definitely the heart is compressing on the lungs in a kind of a way. But if you place the patient prone, so it's kind of how do I explain it now? The compression effect of the heart on the lungs reduces. Like particularly the distal one, because the distal one will even be up. The dorsal one rather, they will be up. So let me see. I don't know if we can picture what I'm saying.
We get it.
You
Yeah, I
get it,
get
Dr. Rishola? Dr. Antonia, do you get it?
No, I didn't get it. Well,
Okay.
all I know is that when you add on prone, if
Dr. Antonia, look at it now. Look at it. This is the lungs. This is the heart up. This is the lung below. This is supine position. If you change to prone, that means that waiting day up, waiting day down will come up, and waiting day down will come. You can see that it's no longer compressing.
Okay, yes.
That is it. So that is the way it works.
Really the pressure of the heart to encourage more ventilation.
So you can, and that compression effect usually is reduced on the dorsal aspect of the lungs where you have most of the alveoli. So you have a lot of free alveoli to get air. So that's why you try to give them prone position. And in this position too, you can clear airway mucus so that it can free that airway very well, so that you can maximize the amount of oxygen that is entering. So that's one of those things you do in severe ARDS with ratio less than 150 at your PEEP level of 0.6. When you are delivering PEEP of 0.6 with your mechanical ventilator, and your PEEP is 5, these two strategies to increase oxygenation. So, because you don't want to take your PEEP more than 0.6, is a problem. If you keep increasing your PEEP, you can tilt that person towards oxygen toxicity. So, while you have maintained your FiO2 to 0.6 and your PEEP to 5, and the person is still having PaO2 FiO2 ratio of less than 150, it means there's a problem, severe problem. So you might want to help by giving prone position. Don't worry, I know that the stuff is a little bit confusing. I will still get to mechanical ventilation and I will explain it well. I just wish they had put mechanical ventilation before this topic. Maybe that's what I should have done. I should have taken mechanical ventilation before I take this stuff, so that I'll be able to understand all these terminologies and the application. But let's just continue. So you have to use mechanical ventilation with low tidal volume to minimize ventilator-induced lung injury by over-distension of the alveoli. I think I've explained this. The normal tidal volume, I think, is about 6 to 8 kg per 6 to 8 mils per kg of body weight. That's the tidal volume that we usually deliver. But we remember that in ARDS, we want to also kind of increase their oxygenation because they are hypoxemic while you are taking care of the underlying cause. And we know the two parameters that you can adjust, to increase oxygenation, your FiO2 and your PEEP. But they will have limits too, because you must not overdo them. If you overdo it, it will be a problem. And you must reduce your tidal volume. Why? Anybody remembers what I said about tidal volume? That when you increase the level of tidal volume to the lungs, what happened? I said something. Anybody remembers that concept?
Of course, a compensatory drop in respiratory rate and also cause
Okay, aside that, there's something else. I said that you don't want to increase tidal volume in individuals with restrictive lung disease.
That it can cause a drop in the respiratory rate.
Okay, yes, aside that.
But there's no, and they're not able to take enough air. So you're trying to reduce the workload for done by the lung.
Okay.
The elastic recoil will be worse.
Yes, that's what I'm trying to remember. So if you give them, too much air, you are kind of like stretching the lung. So the elastic recoil will be increased. So there's something we call elastic resistance. Elastic recoil resistance. So you are increasing it. So, and you know that in acute respiratory distress syndrome, you have already washed out the surfactant. Surface tension is high, elastic recoil is high. So you don't add to the problem and increasing the elastic recoil by giving higher tidal volume. So you keep it minimal so that you don't over distend these alveoli that are prone to rupture and also increase the elastic recoil. Because if you get too much tidal volume, you can over distend the alveoli, increasing the elastic recoil and causing problem. So you give a low tidal volume. You give a low tidal volume in people with acute respiratory distress syndrome because you don't want to over distend the alveoli. That's another point. Please don't let us forget that. Low tidal volume. Most of the time, in most situations, increased tidal volume is not very helpful. You have to keep it minimal. Even if you don't remember the principle, just remember that most of the time you don't give increased tidal volume because you don't want to over distend the alveoli. So if you over distend it, it can rupture. If you over distend it, you can increase the elastic recoil, and you are not helping the patient with the respiratory mechanisms. So you want to give a low tidal volume. Then you want to use your PEEP, just like I've said here, to recruit collapsed alveoli. So you have to titrate both of them, your PEEP and your FiO2. We already know that PEEP and FiO2 are the components that increase oxygenation. So what we do for the mechanical ventilator is that we start from 100% FiO2. We'll not keep titrating it. We bring it down, bringing it down, bringing it down, bringing it down till it get to SpO2 of more than 88. So most of the time, we want to bring it down to a level of less than 60% or 0.6, because FiO2 of more than 0.6 is going to deliver a lot of oxygen that's going to lead to formation of oxygen radical that will damage the alveoli. So you want to avoid that. You want to avoid your FiO2 being more than 0.6. So you'll be balancing your FiO2 with your PEEP, because both of them will improve oxidation. So as you are bringing down your FiO2 from 100%, you are kind of increasing your PEEP, to like 5 or more, a little bit more than that, so that one can help you open the alveoli and preventing collapse that is happening in ARDS due to the loss of the surfactant. So to increase PiO2, just like we said here, you increase PEEP. You increase PEEP. Increase PEEP, increase PiO2. Increase FiO2, increase PaO2, but you must not increase it more than 60% to prevent, you can see here, to prevent possible oxygen toxicity. So your goal is to raise your PaO2 more than 55, or your majorly your SpO2 more than 88%. That's the major target, 88%. So this statement here can be a little bit contradicting, because we already defined hypoxemia to be less than 60%. That's why you see hypoxemia being defined as less than 50 in some text. So, but the summary showed that you want to keep it above 55 and your SpO2, above 88. That's your goal of your mechanical ventilation. So while you are trying to, treat the underlying cause, you are also doing this. You want to place the patient on mechanical ventilation. You want to improve oxygenation. How are you going to improve oxygenation? Increase FiO2, increase PEEP, but you are going to titrate them, because you know that if you increase your FiO2 too much, it's going to cause oxygen toxicity. So you don't increase FiO2 more than 60%. You increase your PEEP to like 5, so that you can balance it with your FiO2. At the same time, you don't want to increase your tidal volume, because if you increase tidal volume, it can overdistend and rupture the alveoli that are opened by your PEEP. And at the same time, you don't want to increase the elastic recoil, which is already very high in people with ARDS. Those two things. So, you might decide to put a prone positioning, particularly when you have value of less than, you have ratio of less than 150. Your P small AO2, FiO2 less than 150, you want to, give them prone position. Let me shed more light about this ratio again. Now, if you are intervening in this patient, what we are going to be doing is that we are going to be increasing our FiO2. So what do we think should happen to the PaO2? Dr. Lushola, we are increasing our FiO2 so that we can increase oxygenation. What do we think should be happening to PaO2? Dr. Lushola?
Should increase.
PaO2 should be increased. Now, in a setting, PaO2 should be increasing, but in a setting where there is failure, that the stuff is not even responsive, what will be happening to the PaO2 as you are increasing FiO2? If it's failing madly, PaO2 will still be decreasing as you are increasing FiO2. So you notice that your ratio will keep decreasing. That's why the lower your ratio, the worse the condition. I don't know if what I've said makes sense to us. Like to intervene, if the patient is actually improving, as we are giving FiO2, your PaO2.
It's a measure of severity, I think.
Yes. So it's a measure of severity. So that's why they will say that when the stuff is less than 150, that means it's getting bad. Because at that 150, you have increased your FiO2 and you are still getting low PCO2. Because you know that the higher your FiO2, the lesser that ratio. I don't know if you guys know. Like, let's say that PaO2 is 300, and my FiO2 is 100. So that means in this state, my ratio is going to be 3. Now I want to intervene, but this patient is not improving. Look at what will happen. You have intervened, you have increased PO2 to 200 from 100. Now your PO2 is not now increasing. Your PO2 is now decreasing to let's say 100. This ratio is going to be 0.2. We can see that it has decreased from 3 to 0.2. So you lesser your ratio, it means the worse the person is getting, because you are increasing FiO2 and PH2 is still decreasing. Do we understand that analogy?
Yes, please.
So that's the way it works. So there's something we call permissive hypercapnia. Permissive hypercapnia is you allowing the patient to be a little bit hypercapnic. You see this in the question stem. You are allowing the patient to be a little bit hypercapnic so that you don't increase tidal volume. Because we remember that we said that the way you can take care of hypercapnia is what? By increasing what? Who remembers? How do you take care of hypercapnia? Anybody remembers?
NPPV.
Respiratory rate.
You increase respiratory rate. And what are the respiratory rates? No, not only respiratory rate. What umbrella term?
Ventilation, increase ventilation.
Ventilation. And what are the components of ventilation?
RR and VT.
RR and VT. Now, it means that if I want to take care of my hypercapnia, I have to increase either VT or I increase RR. Now, in people, in individuals with ARDS, I know that I must not increase VT. So what I'm going to do is I'm going to allow them to be hypercapnic. So that's the concept of permissive hypercapnia. You will lower your TD and allow permissive hypercapnia is better than you increasing tidal volume and causing volume trauma and over distension of your alveoli, and further worsening the distress. So this permissive hypercapnia is not a very severe one. It's just minimal. It's not like extreme form of hypercapnia. So you normally see that statement. They do that phenomenon in mechanical ventilation for people with ARDS. You allow for permissive hypercapnia so that you can keep the tidal volume low ventilation, causing the hypercapnia so that the patient doesn't get too much volume of air over distension, rupture. So don't forget permissive hypercapnia. Don't forget. So when do you now extubate? When you have treated the cause and the person has improved. So the person is no longer hypotensive from shock. The person is now improving. The temperature has gone down. The respiratory rate is now stable. You know that, okay, this person has recovered from the sepsis. When you just require minimal support, you don't need to be giving high FiO2 again. You don't need to be giving high PEEP to oxygenate. Your ventilation support is minimal. You can extubate. When oxygen supplementation is easily accomplished without needing to be increasing FiO2 or PEEP. When a patient passes a spontaneous breathing trial. So in this condition now, you can allow the patient to try and ventilate on their own. So what we are going to do is that we are going to disconnect the mechanical ventilator and we are going to place the patient on a machine that is going to be delivering pressure only. Who remembers an example of that kind of machine that I said? It's not supporting the ventilation, it's just delivering pressure. Anybody remembers? What would be that example, that kind of machine?
Is it BiPAP?
Any of
Yes.
CPAP or BiPAP?
Yeah.
BiPAP.
So any of the CPAP or the BiPAP, they are not controlling the ventilation. So you now see the patient, is it actually ventilating? If the patient is doing well and ventilating, so you can say that, okay, this patient has passed the spontaneous breathing trial, then you can extubate. There are so many other things that you can do to test this spontaneous breathing trial, but that's just an example. So I don't know if we should talk about mechanical ventilation before we call it a day. Should we?
Let's do it tomorrow.
Let's do it now, Gary.
Dr. Antonia, that's so unusual. Dr. Antonia, I know
there is recording now, Dr. Antonia.
I think our brain, I'm joining her. The glycemia is dropping now.
Hey, you watch the video now.
But also, don't be selfish because don't selfish here.
No, he's not being selfish. The video is there.
Mechanical ventilation is a little bit stuff, but
It's huge. And if we're not
So
paying
it's
attention,
huge. Let's do it when we are paying attention, please.
if
I
we're not
beg.
paying attention,
Tomorrow.
no, it's
Tomorrow.
helpful.
Aye.
okay,
It's
no,
tomorrow.
no problem, no problem.
So much.
Let me
See
see.
You're
that we
enjoying
see,
your lecture, but so
we
we're
see how
enjoying your
many
lecture.
videos that we
We
watch.
just want to follow. We just want to follow you back to back. I mean, I'm enjoying your lecture.
Yes, yes. Dr. Antuna, don't put it to my head, Jare. Me,
You're
I,
enjoying your lecture.
Dr. Baba, we need to enjoy the lecture. We're enjoying it. I think
Yes, you're enjoying your
I
lecture.
know
That's what
that
I'm saying. So we
I know
follow
that the
you.
lecture is a little bit, you know,
So let's take it together.
no, I said let's take it one by one now. Dr. Antonia,
That's
what do
The
you
one on one you are just saying is different.
that because our
You want
brain
to
are
read your own, I read my own. Is that
our
what you're
brain
saying?
is tired. Ah,
so now what did you say?
our brain is having a kleptogenic focus now. So we have to take it.
Antonia.
a joke. So I don't know. Yeah, let's try.
Yeah, we can
So
take it one after the other. Why not?
I don't want to put anybody on the spot. You know, all of us we are just learning. So let's just take it general. It's no problem.
Okay.
A 35-year-old woman is evaluated at the bedside due to new onset, rapidly worsening shortness of breath and hypoxemia. A day ago, the patient was admitted to the hospital for sepsis due to ascending cholangitis from gallstone obstruction of the common bile duct. Endoscopic retrograde stone removal was performed shortly after admission, and she's receiving intravenous fluids and broad-spectrum antibiotics. Temperature is 38.9, blood pressure is 102, pulse is 118, respiration 35, oxygen saturation is 84% on a non-rebreather max with FiO2 at 90%. The patient appears anxious with labor or respirations. Cardiovascular examination demonstrates normal heart sounds, normal JVP, and warm extremities. Pulmonary examination shows faint wet crackles diffusely. The patient is intubated and she is transferred to the intensive care unit. X-ray, I don't get this. Okay, I have it. X-ray is shown in the image below. I will show us the X-ray. ECG shows sinus tachycardia and cardiac troponin high. Troponin high is normal. Bedside transthoracic echocardiography reveals hyperdynamic left ventricular contraction and trace mitral regurgitation. But blood cultures are negative and gram stain shows no organism. Which of the following diagnostic tests is indicated at this time? So let us see the X-ray. So this is the X-ray. Okay. So yeah. So what can we make out from this? What do we think?
Although you've taken the X-ray out, I can see opacity like it's whitish. I don't know. I can't see the X-ray anyways. I don't know if you've taken it out. Am I the only one? Yeah.
Is this bilateral? Is it bilateral?
It looks bilateral, but I would say the
No,
left
it's
part.
bilateral.
Is bilateral.
Yeah.
See, Dr.
It's
J, this is
bilateral.
the normal diaphragmatic. So this guy here is gone. This is diaphragmatic part.
And the ankle. Yeah, the lower part again, the blunting thing.
Yeah. So let's just read it again. So a 35-year-old woman is evaluated at the bedside due to new onset, rapidly worsening shortness of breath and hypoxemia. A day ago, the patient was admitted to the hospital for sepsis due to ascending cholangitis from gallstone obstruction of the common bile duct. ECRP was done shortly after admission, and she's receiving intravenous fluid and broad-spectrum antibiotics. The temperature is elevated, blood pressure is 102, pulse is increased, respiration is increased. Oxygen saturation is 84 on a non-rebreather max with FiO2 at 90%. The patient is anxious, labored respiration, CVS with normal heart sound, normal GVP, and warm extremities. Pulmonary examination shows faint wet crackles diffusely. Patient is intubated and she's transferred to the ICU. Chest x-ray is this. And this is also the cardiac finding. ECG shows sinus-cardiac, this. So
What I noticed is that the chest X-ray is less than 24 hours, isn't it? After she's been.
no, a day ago
A
she
day.
was admitted,
More
and
than
she
24.
developed this symptom after a day, and she
After
had
a-
sepsis.
It's consistent with ARDS, isn't it? If it
That's
was
the
less,
ARDS.
thinking
Is
of,
there RDS?
That's the ARDS.
yeah. Mm-hmm.
So they are trying to tell us that she doesn't have heart failure.
Yes.
That's what they ruled
Normal
out the
GVP, the contractions are good. Left ventricular
Mhm.
contraction are hyperdynamic. It's contracting. So that's why they have ruled out heart failure for us. That's what they are doing. So what do we think for the answer? What are we going to
But
do?
what about the bedside transthoracic echocardiography?
Yeah, that's what I'm
Revealing
saying. It's good. See, hyperdynamic left ventricular contraction is
Has already been done.
hyperdynamic is contracting, even hyper. Do you know why it's hyper? Because of that hypoxemia. You have to even be working more
making up
than
for
normal.
stroke volume.
Yes. To meet up.
So this is not a cardiac problem. So what do we think? Let's just put a guess to it based on what we have learned. Like, just
If we look at the options, from the
Yes.
options,
yes,
I would go with no additional testing.
fantastic. Everything
Because-
you need.
Sense,
you
yeah.
have picked it. Okay, so what
Done.
does high resolution CT scan wants to do for us? Is this interstitial lung disease?
No.
So why are we doing lung biopsy? Why?
Mm.
Why? What are we looking for? What is going to be the finding of biopsy for ARDS? So that's why most of the time, before we look at option, we have to have like a diagnosis running through our mind. It's going to guide us. So pulmonary arterial catheterization is only done majorly for pulmonary hypertension.
Okay. Pulmonary hypertension, yeah.
They told us that this person is hyperdynamic contraction. Why are we doing echo? And it's even transophageal again. What's the person looking for? Is he looking for aortic dissection or is the person looking for thrombus? So no additional testing. Diagnosis of exclusion. You have excluded all you need to exclude. You have picked out your clinical symptoms. You have your investigation to back it up. You are okay. So no additional testing. That's the answer. So let's look at the next one. A 44-year-old man is admitted to the hospital due to severe abdominal pain and vomiting. The patient reports drinking about 10 shots of whiskey daily for 6 months. He has no other medical conditions. The patient is diagnosed with acute pancreatitis and received IV fluid, pain control, and NPO. On the second day, he reports a sensation that he cannot get enough air. The patient is afebrile. Physical examination shows bilateral crackles. The X-ray reveals bilateral diffuse alveolar opacity. Echo shows normal left and right ventricular function without major valvular disease. He undergoes endotracheal intubation and mechanical ventilation due to progressive hypoxemia. Which of the following treatment strategies is most likely to decrease this patient's risk of in-hospital mortality? Nice. Let us see the people that are actually paying attention. So let us see now. Please just read the option very well. I know we know it.
Increasing ventilation in ventral lung regions.
Dr. Antonia, which region did I call it? Please.
Dorsal.
Dorsal. So that one is gone. That one is
That
gone.
one, that's dorsal. About dorsal.
Dorsal. Oh.
Preventing overdistension.
Prevent alveolar overdistension, reducing time to volume.
Yeah,
Okay,
the tidal.
please. Let's keep one like that. I just want somebody to just help us with why A is wrong.
This side.
So that you won't be able to recruit more alveoli.
No.
No, to to
Avoid
prevent
Ebola
reduce
hyperventilation.
tidal volume, just permissive hypercapnia.
Fantastic. Permissive hypercapnia. That's why that one is wrong. We have to do alveolar hypoventilation because we want permissive hypercapnia. Many people will just sit down and go and pick it and they will fail it because it makes sense. You should avoid alveolar hypoventilation now. Like, why should we hypoventilate the alveoli? Like, this person doesn't have enough oxygen, so why should we hypoventilate? So don't let us hypoventilate. That should be the wrong one. But you can actually reduce the tidal volume to allow for permissive hypocapnia. And if you reduce the tidal volume, it means you're actually kind of hypoventilating. Because the way you can reduce the tidal volume is by hypoventilating. So that's the concept we are trying to drive out with that. So that's a good one. You prevent alveolar overdistension, so that you don't, collapse that stuff. So
increase the elastic recoil.
you can see that it's already getting endotracheal intubation and mechanical ventilation. So you have to prevent alveolar overdistension by reducing the tidal volume to the minimum, at least less than 6 mils per kg. I think that's all. That's all. Well, it's fair enough. At least, for I don't think I have
2 good questions.
Yeah, 2 good questions. 2 good questions for ARDS. I will have added more if I know that I'm going to take that class. Okay, let me see. There's one here. Okay, let's look at this one too. This one is basic now. So
No,
a 28-year-old man. No, we have not done it. I've seen it.
Okay. I wanted us to try. Okay.
We have not. Oh yeah, let's try. I don't. Have we done it? Okay, we can try. We can try. A 28-year-old man develops headache, nausea, cough, shortness of breath, fatigue while hiking the Mount Whitney Summit Trail in California. The patient arrived 3 days from Los Angeles. He was also accompanied by his friend who came from New Jersey, where his friend doesn't have any symptoms. The patient has no medical condition and takes no medication. He drinks 3 to 4 beers every day. Temperature is 38, blood pressure is 130, and pulse is 120. Oxygen saturation is 85. Examination shows cyanosis, dry mouth, bilateral crackles. The X-ray reveals diffuse patchy of infiltrate and normal outside. Laboratory shows leukocyte of 14,000, 74 neutrophils, serum procalcitonin of 0.1. Normal is less than 0.5. What's the most likely diagnosis? Okay.
The patchy infiltrate, isn't it looking like pneumonia?
So which one are you going for?
And the fact that he's hiking, it looks more like as if he's having this high altitude.
Yeah.
Let me see. Strep pneumo.
Which one?
Nope.
I'm looking at non-pathogenic pulmonary edema.
That's the answer. This is like high altitude.
Oh, it's very funny because
but it's very funny.
It's signs of because pulmonary edema will be more of the increased AA gradient, isn't it?
Yeah, but you can't calculate the A gradient from these parameters. How did you know?
Just conditions under them that involves the lung. Wouldn't it fall under? I'm just saying, with the little knowledge we have from step 1 and 2, wouldn't it be under the increased AA gradient?
You mean this condition? Yeah, definitely. But what I'm saying is, like, we cannot even calculate it because we don't have PaO2, we don't have anything. But it's definitely going to be an increased AA gradient problem because it's affecting the lung.
Okay.
So, but this is high altitude pulmonary edema. But I think I'm going to find a way to smuggle it. So
yeah. So, but Dr. Bawale, what do you say about the fever?
The which one?
38.3%.
The
In
patient
this case, their temperature is 38.3. And
pneumonia.
why
Yeah,
non-cardiogenic?
they are just using that
disease.
one to distract. They want to tilt our mind towards infection. That was why
Mm.
they put the fever there. But this is the criteria. Your procalcitonin will be normal. They are going to have mild or absent leukocytosis, and the leukocytosis is usually less than 14K or equal or less than 14K. And they will have recent arrival at the high altitude within 1 week. So if this is strep pneumonia, procalcitonin will be high. We remember that procalcitonin is an acute phase reactant.
Phase reactant, and they will be upregulated.
It will be upregulated. This person is going to have leukocytosis more than 14K. That's another thing. So that fever is just there to just distract us, you know. So this person has high altitude pulmonary edema. They can also have fever, and they will have all these other. These are the major criteria to make the diagnosis. So we are going to look for a way to smuggle it into the lecture, you know, because it's not actually. Well, even if somebody is thinking of something, well, maybe the only diagnosis that somebody can think of and can make one fail this question is strep pneumonia. I think that's the only thing, because we think that leukocytosis is normal. This is 14,000, you know, with even 74% neutrophils, but this procalcitonin level is not supportive. It's not
If
supportive.
somebody knows the procalcitonin, you won't go for it.
You won't go
Yeah,
for it at
exactly.
all.
That's what I'm
because
saying. You won't go for it.
that's-
You won't go for it.
if you rule out, the only thing that is left there will still be the pneumonia would make it, but the added aspiration, so that aspiration takes it off.
Yeah, I think we have. I'll put in. So this is another one. A 53-year-old.
So, what are those criteria for high altitude again now? Sorry.
So arrival at high altitude within 1 week.
Okay.
The condition is correctable by oxygen. Your procalcitonin level is normal. Then leukocytosis 14,000 and less.
Okay.
So a 53-year-old man, homeless man, comes to the emergency department due to several days of shortness of breath and productive cough. A month ago, the patient was evaluated for dysphagia and was found to have candida esophagitis. He received nystatin but refused any further workup and left against medical advice. The patient uses cocaine and intravenous heroin. Temperature is this. Blood pressure is normal. Pulse is 124, and respiration rate is 22. Oxygen saturation is 89% on 2 liter per minute of oxygen by transfer cannula. Is awake, alert, and has a mild respiratory distress. There are extensive white plaques over the oral mucosa. A 2/6 mid-systolic murmur is heard at the left upper sternal border. Lung auscultation is remarkable for faint bilateral crackles. There is no jugular venous distension or lower extremity edema. Which of following is the most likely underlying mechanism response for this patient? Hypoxemia. What do you think? What do you think? What do you think? What do you think?
I was thinking TB when I saw the homeless guy. But the fact that he's using pneumonia, it might be pneumonia too.
Okay. So what kind of pneumonia is going to be?
This is an IV drug user.
He's
So,
an IV drug user, so strep pneumo.
Okay.
yes.
So
An
if this
infection.
is strep pneumonia,
Mm-hmm.
if this is pneumonia, let's say strep pneumonia aspiration, but this person most likely had aspiration pneumonia.
Mm-hmm.
You know,
Mhm.
it's
So then-
dysphagic. They can't swallow. So if
So
I,
ventilation perfusion mismatch.
so which one are we going for? Is that what we
E.
are
It is
going
still the ventilation.
Cannot swallow. The dysphagia.
Yeah.
Yeah,
Then
this way. The beginning.
we did not focus on that. He has dysphagia. And he's having
Mhm.
immunosuppression in a way, candida. So, strep pneumo might be correct, but strep pneumo is not, is it the commonest, the aspiration pneumonia? Your
Yeah,
grandmother
we have
said.
all those.
Depression
The
is also a
and
lot
the and
in
then
mild respiratory distress.
the what?
Depression is also a lot and in mild respiratory distress.
Yes.
Mm-hmm.
And you also have crackles, bilateral crackles. So kind of, is it an
Is it what?
infection, something going on, inflammation?
Yes. Look at
So
it. It has fine bilateral.
Plurally is E.
It's
That's
going
why
to
it's
be
E.
E. Rule
That's why
out.
it's E. I know we are
it's
correct.
yeah, no,
Mhm.
in bilateral crackles.
Those
So
other options
kind of
don't make sense.
pneumonia and also
But why is it not
Exactly.
okay? It's because of the way they said this question. I would have liked. Oh God, I wanted to change
I
this
know
to right to left.
Dr. agree because the rest of the option doesn't make sense.
The rest
Increase
of the
on
option doesn't even make sense. Actually,
That's
you are
why
very
I
right.
already said it.
If
for
you
the
change
heart.
this one to right to left, some people actually fall
Mm.
for it and think this is shunting. But why would not? Why won't we consider shunting here?
Be-
It will be very bad. The condition will be very bad.
You get the
and
patient
the
will
guy,
be very
It
bad.
won't be mild respiratory distress.
God bless you.
yes,
Like
because oxygen we have.
like the
He's
the
what?
oxygen sat is
A
even
lot
kind of
of
good a
respiratory
little, like 89 now. 89 is okay. It's
distress.
like
Mhm.
it's beyond 88. Patient is awake. No be short
He's
thing
an
like that. It's a lot too. I think maybe they knew that JJ, that's why they could change it from left to right.
And
So the answer
no,
is
no.
ventilation. None of the
Yeah,
answer actually made sense. The option was
honestly,
it was actually very easy to pick up.
it's
yeah,
very,
yeah.
very easy.
Yes.
The common cause of pneumonia in people that are immunosuppressed is strep pneumo. So
Mm-hmm.
so and what else again? Where is the location of the faint bilateral crack? Okay, they are not actually specific
Mention it.
in where the person had
Mm.
the stuff. Okay, so but from the crackles, from the fever, we know that definitely this like pneumonia that we are
Mm-hmm.
dealing with. Okay, I don't think I have any other one. At least with the little knowledge that we have, at least we are getting questions right too. That's okay. So I guess we have to call it a day then.
Yes.
All right.
Thank you so much.
Dr. Wawale, it's like this time is
If
good
we
for
are
you,
going
all right?
if
Is this a good for you, Baba?
if the what?
Is
Is
this
this
time
a
good for you?
I can't really say. Not
It's
quite
like
sure.
we can do more with this time.
Yeah,
Yes,
don't
we
mind
can come up with this time, so we don't mind this
I
time.
don't mind actually.
Sometimes I have to go to school, so I don't
No,
come
no,
back
it's
very late.
for you.
Like,
Maybe when you have your classes now, we can maybe go by your time.
Yeah. Anytime there's work that works for you, it's fine.
okay, thank you so much for your
And
understanding.
thank you for this. Leslie, thank you.
No
Thank
wahala.
Dr.
So
Are we meeting?
please, if
Maybe.
we are meeting
Yes,
tomorrow, I will let Dr. Olushola know.
Okay.
Okay.
So that we will know, because if it is tomorrow, it will not be like today's evening.
Yeah,
for us.
Dr. Sola, please just put the date.
Which dates? You should know the next class.
No, we can't definitely meet. We can't meet in the normal class that we meet that time because it's already very close to
No.
midnight.
It's 9 already.
We're telling Dr.
I
Dr.
understand what they are saying.
You
Okay,
understand?
okay. Well, I don't understand
So
what
that'll
American
be for next tomorrow.
what you American people. It's even funny that I'm the only one that is not in America in this set. Oh my God, I have to move. All the people I'm dealing with here, they are American.
But Dr. Baba, if like today, like tomorrow, your time you'll be free like by this time tomorrow too. We can still take
Yes,
the class.
I should be free. I will be free by this time. I would like to
Then we
put
can also take it by this time too. It will be perfect for you too. Because it's
yes,
actually better.
yes,
It
yes.
can't even be in the morning because here in the US, that means we should be getting ready for you in the next 6 hours.
That's it. That's what I'm saying. So